from? What part of the world have you come from? If you use the chat box to let us know where you're coming from. Who will be the first person to type? Thank you. Ebenezer is from Essex. Thank you so much. Welcome, welcome. Glasgow, thank you. You're welcome. Durham, thank you so much. Essex again, Nigeria. Thank you. If you keep typing, where are you joining us from? What part of the world have you come from?
Sale.
Oh, Still.
Where is Sale?
That? Kwanzi. Eswatini.
Oh, hello, Fola. Thanks for joining
Hello,
us. How you doing?
Nigeria. Thank you, Judith. Wow. We got people from everywhere. Ghana as well. Thank you. Thank you so much. Before we go, we're just gonna have a few housekeeping rules. Please, we know that we're all virtual. Try and get yourself a glass of water. Feel free to have your notepad and your pen. I believe that you would definitely write some notes. I've joined, I think I join Encapsulator all the time, and I always have something to always take back. It's always very informative. So yes, Akure, Damilare, welcome. Thank you so much. And obviously, this is very important. Can we kindly mute ourselves? If you're not talking, mute yourself. Feel free to let us see your face. We would love to see your face. It would be good to, put a face and a name together if you can. And yes, it's 4 o'clock. We're just gonna go diving in straight away. I'm going to call on the host of Encapsulate, who is Flora, to just give us a bit of introduction. Thank you.
Good afternoon, everyone. Thanks for joining this edition of Own Your Health. I'm Flora. I'm Flora Coker, the founder of Encapsulate Healthcare Solutions, an organization I founded to empower our people with information about their health so they can make better decisions about their health and the health of their families, and of course, people around them as well. We only share factual information, and that's what we want to get across to you, so that you're equipped with the facts, the truth, the science about various health topics. Thank you, Bumi. Back to you.
Thank you so much. I'm going to be your moderator for today, so you're in for a good time, trust me. Whether it's funny, whether it's not funny, just give me a smile. I love to see people smile, all right? The only thing I'm going to tell you is when you have a speaker speaking and you have a question, please do type your questions in the chat. If you can start your questions with a Q, so then I know that that is a question. And after the speaker has finished speaking, then we will get the answers in. So the first speaker for tonight is Kemi Oduniyi, who is going to take us on what is depression. What is depression? So Oluwakemi Oduniyi has been a qualified pharmacist for 18 years. So that means she's a master in this game. She's currently a principal pharmacist and a clinical lecturer. Kemi is a committed Christian and enjoys to serve a community. And this is part of service, why she's here tonight. So with a virtual drum, if we can just give Kemi a high five, give her a welcome, give her a virtual love, and I'll just leave Kemi to, help us to share. Thank you.
Hello, good afternoon, good evening, wherever you're calling from. Good afternoon, everyone. Flora, I'm not able to share. I don't think I can share. Oh yeah, I can now. Can everyone see my slides? Yes.
Yes.
Okay. That's fine. Okay, so good afternoon once again, and thank you, Bumi, for the introduction, and thank you to Flora for giving me this opportunity to share. Thank you so much. and I just welcome everyone once again. And so today, like Bumi has mentioned, I'll be talking about clinical depression and what is clinical depression, the signs and symptoms to look out for, the causes of depression and severity of depression. So sorry, I'm just, I don't know why I can't click off. It's normal. Okay, yeah. Sorry. So before I go on to what clinical depression is, I think it's important to understand what a mental health illness is. So a mental health condition is a condition that impacts on the way we think, on the way we feel, and on the way one behaves. And this feeling can be either a low feeling or a high feeling. So I thought that it would be important to explain what a mental health illness is. You know, just like people suffer from diabetes and asthma or heart disease, the same way mental health can be impacted as well negatively. So it's essentially how we feel, what we're thinking about, and our behavior. So those three things. There are, you know, different types of mental health disorders, and depression is one of them, which I am going to be talking about. We have other mental health conditions like schizophrenia, anxiety disorders, and dementia. So today we're looking at depression. I am looking at depression, and my other colleagues also will be talking about different aspects of this. And depression can affect all age groups, you know, from young people up to older adults. So it spans across all age group. So these are key facts that I thought it would be important to share with you. At the moment, there are about 350 million people, or even 380 million people who are experiencing depression worldwide. The statistics that I have here is from WHO 2017. That says about 300 million, but that's increased recently to about 350 million people that suffer depression worldwide. And it's more common in women than in men. 5% of the adult population globally suffer depression, so it's a common illness worldwide. It's also a leading cause of diseases, is a leading cause of disability worldwide. So a leading cause of disability worldwide, and it can lead to suicide. So that's why it's important that one knows about depression. It's predicted to be the leading cause of burden by 2030. So by 2030, it's predicted to be the leading cause of burden. And suicide is actually the second leading cause of death among people ages 10 to 34 who suffer depression. It's very treatable, but apparently about 35% of adults receive no treatment. So during the pandemic, the adults, this is a data from the British population, adults reporting moderate to severe depressive symptoms increased. So between July to March 2020, about 10% of the British population were reporting moderate to severe depression. And by June 2020, that increased to 20%. And 13% reported that the moderate to severe depressive symptoms developed during the pandemic. So the pandemic has also impacted on the mood of the population. So what is depression? Depression is more than just simply feeling unhappy. Maybe you did a test, or you didn't pass your driving test, and you feel unhappy for a few days, or feel fed up for a few days. It's more than that. Clinical depression is feeling persistently sad. So feeling persistently sad for weeks or months rather than just a few days. But the good news is that there's right treatment, there's support, which people can access, and they can experience a full recovery. So what I just wanted to also highlight that it's important not to trivialize depression, because some people will say, oh, depression is not a genuine health condition. You just make it as if it's not important. But I'm here to say that it's a real illness with real symptoms. Depression is not a sign of weakness or something that you can snap out. So you say to someone, oh, come on, snap out of that, pull yourself together. It's more than that. It's a genuine health condition that would require attention. This is a quote from someone who suffered depression. The person said, when I'm depressed, it is like being stuck at the bottom of a deep, dark well. The sides of the well are slippery, almost glass-like. I'm unable to claw my way back up the well, as when I try, I just slide back down to the bottom again. So you can see the state in which a depressed, somebody who is suffering moderate to severe depression, the state that it's a really sad state where they're at, and they do need help. So what are the causes of clinical depression? One of them is bereavement, relationship breakdown, loss of job, personality as well. Personality traits can make us more vulnerable to depression. So someone with a low self-esteem or being overly self-critical. Family history of depression as well can be a cause of clinical depression. Giving birth, for women who have babies and end up having postnatal depression or perinatal depression. Alcohol and drugs, so, substance misuse, loneliness as well can cause depression. And people who have got a long-standing illness, they are at high risk of having clinical depression, so such as coronary heart disease, cancer, thyroid disorders. So there are sort of three classes of symptoms of depression. You have the psychological symptoms of depression, you have the physical symptoms, and you also have the social symptoms. So when we talk about psychological symptoms of depression, these are some of the things that you would see in someone who's got this psychological symptoms. So feeling of guilt, hopelessness, irritability, low mood, sadness most of the time, anxiety, they're anxious, they're very tearful, and drug and alcohol abuse as well. So sometimes people use drugs and alcohol to sort of mask the depression, to help to mask, but actually it takes you more into depression. That's what people don't know. The other symptoms of other symptoms of psychological depression is when you're having suicidal thoughts or thoughts of harming yourself, lacking motivation. We have the physical symptoms. The symptoms are fatigue, sleep disturbances, unexplained digestive problems, so things like constipation, sexual dysfunction, unexplained aches. From some people, they don't know how to express themselves. It might come as somatic symptoms. So unexplained aches and pains, those might be symptoms of depression. Moving or speaking slowly, more slowly than usual, also can be one of the physical symptoms of depression. The other thing is changes in appetite. And this can mean you're not eating as much or even eating too much. Social symptoms. The social symptoms of depression are, number one, avoiding contact with friends and taking part in fewer social activities. So for example, if maybe your next door neighbor is someone who is usually cheerful, you see them when you're going to work, you say hello to them and they say bye, and all of a sudden they're passing by and they just ignore you, take their face away, rather than think, oh, they're snubbing you and you go away resenting them. It might be that there's something actually going on there, where they don't want to relate with anyone. It could be your co-worker as well, who is always lively, friendly, and all of a sudden they don't want to talk to you. Instead of saying, "Oh, I saw my, my co-worker, she just snubbed me, he just snubbed me." There might be something going on. Neglecting your hobbies and interests, so losing interest in something that you used to like. If you like playing tennis and all of a sudden you just decide it doesn't interest you anymore, or if you have a favorite program that you watch on telly and all of a sudden, I don't know what the favorite programs nowadays are, but and you don't watch it anymore. And having difficulties, so when you're having difficulties in your home or work or family life, those are some of the symptoms, social symptoms of depression. And in terms of severities, from mild to severe. So the mild one has very minimal impact, just some impact on your daily life. With the moderate one, it has a significant impact on your daily life, whereas the severe depression, this is almost impossible to do anything on a daily basis. And this can actually lead to psychotic depression. And this is where, one needs to seek help when it comes to depression and not trivialize it. It can lead to fatal outcomes. I remember speaking to my aunt yesterday, and she was just telling me about a story which she had told me many years ago. Now, I just asked her yesterday to remind me of the story again, where one of our friends was actually stabbed to death 42 times by a partner. So a partner killed my aunt's friend, as well as their 8 weeks old baby. Here in the UK, they had just come from Nigeria, but not knowing that this guy had been having depression, and which remained untreated. Nobody knew about it because this lady did not know the symptoms of depression, so she could not ask for help for her partner, and so that led to loss of life, losing to people. It was a very high profile case in the UK about 30 years ago. And so when you're looking at diagnosing depression, when you go to healthcare workers here in the UK, this is what some of the healthcare workers use. They use the patient health questionnaire. And this means that they ask you how long you've been having the symptoms for. So there are core symptoms of depression that they look out for, things like persistent mood, low mood, lack of energy, and loss of interest. And if you've been having these symptoms persistently for at least 2 weeks, you're being scaled. It is a number. You can actually use this as a self-assessment, but of course you need to involve the healthcare professional as well. And so this is another case study of a 21-year-old Black young lady, undergraduate law student, which she was brought to hospital by her parents because they were very concerned about her deteriorating mental state. It was impossible to get any information from her as she was mute, not responding to questions, and her father was asked to give an account of what had been going on. And the father said that it all started about a year ago, where she was studying for her first academic year at uni. So she didn't do well in her exams at the end of the year. Her program was discontinued as a result, and she was advised to go to another uni. She was later seen by a GP for low mood and negative thought and was referred for counseling, which she did not attend, so she did not cooperate with. So this is what we see, especially amongst the Afro-Caribbeans. We don't always engage with treatment. We don't engage with healthcare professionals when it comes to mental health. And so by the time you're left untreated, it's even hard to even treat. It goes into psychosis, a lot of times. So when you seek help, when you experience symptoms of depression for most of the day, every day for more than 2 weeks. And it's particularly important to speak to a doctor. If you have symptoms of depression that are not improving, your mood affects your work, other interests, and your relationship with family and friends, and thoughts of suicide, or you're having thoughts of suicide or self-harm. And so I'll just give you a few seconds to read this. This is just about when you're seeking help. Yes. So when you're seeking help, it's important to be honest and be open, because in mental health, this is my final slide. In mental health, we don't have metrics as such to carry out a diagnosis. Like when you have blood pressure, you can do blood pressure readings and say, oh, okay, your blood pressure is 140/70, is going down or is going high. But in mental health, it's not like that. The doctor would rely on the information that you give to the doctor. That's what the doctor will use to determine whether you have depression and how severe this depression is, as well as, and that will enable you get the appropriate treatment. So that's when you're seeking for help. Make sure you're open and honest. So thank you so much. I think my time is up. Thank you.
Thank you so much, Kemi. Thank you so much for those facts and numbers and figures on depression. If you have a question, if you can type it into the chat, starting with a Q, or you can just put your hands up with the virtual and I can just unmute you to ask your questions. Or did she deliver so well that we don't even have any question? As she summed everything up. If you have a question, you can just raise your hands up. I think that'll be the quickest way. If you raise your hands, then I would unmute you and then you can ask your question.
Kemi, please stop sharing.
Okay, I've got someone. Okay, I've got Shion Afilaka. So I'm going to ask you to unmute, sis. Good afternoon, sis. Yes, please. Thank you.
Hello?
We can hear you.
Can you
Good
hear
afternoon.
me?
Yes.
Can you hear me?
Yes, sis. Good afternoon. We can hear you.
Okay. Good evening, everyone, or good afternoon. Thank you for, the presentation. You talked about the rate of suicide, if I heard well, depression, in women, that the rate of depression is in women is more than men.
Yeah.
I just wanted to find out the relationship between the depression and suicide, because research also showed, and correct me if I'm wrong, that the rate of suicide in men is higher than that of women. So I just wanted to know the connection between the two, please. Thank you.
All right. So I don't have any specific data on that, but in terms of why women tend to have more depression, the rate of depression is more, it's probably because they tend to seek help earlier on than men. That's number one. Number two, women tend to go through more stressful life events, so like giving birth. And then number three, with women, there are hormonal issues as well. So the hormones can have impacts on our mood. So in terms of women and men having higher suicidal rate, it's just my belief is that because they don't seek help early. I gave the account of this man that stabbed the family and killed his partner and the only child, about 7 weeks old baby. It's because they don't seek for help early. They mask their symptoms, and so by the time everything comes out, it's a bit too late. So yeah, I hope I've managed to answer your question.
Is that okay? Okay, yeah, she's written down to say true in the chat. Yeah, I'm not an expert, but I would definitely agree with that. I was already thinking in that line of thoughts, that men, don't tend to seek help. I think it's the egoistic thing. So if a man here, maybe you have a friend or you have, and you see all of the signs that are there, please let us be kind to one another, so that people can easily talk to us. And depression is not written on the faces as well. It's something that, we don't see. So let our words be kind to other people. So the second question that I've got for you, Kemi, is, are the symptoms of depression slightly different in Afro-Caribbeans compared to that in Caucasians?
Again, having worked in the mental health setting for the past 15 years, I haven't seen any major differences in terms of their in the way they appear, or the symptoms come. But I think one cultural difference that I mentioned earlier on in my slide is the pain. So for some culture, they might see it as pain, or I'm having this backache, I'm that back pain. But generally, the symptoms of depression is similar across culture. So it's not one culture has this, and even the prevalence is similar across worldwide. The prevalence, everything, most of the data around it is very similar. Sorry, that's my alarm. Yes, so yeah, I hope I've answered that.
Thank you. And the last question that I have for you, hopefully, it's the last one, is why are African Caribbean overrepresented in mental health system? I'm not sure of that question. If you're Galaxy A03S and you've asked that question, maybe put your hands up. We can unmute you so that you can give a bit more clarity. I think we need a bit more clarity on that question. Why are African or Caribbean overrepresented in mental health system? If you're that person that has asked that question, maybe put your hands up and we can unmute you so that you can just give a bit more clarity. Anyone? Or if you can just unmute yourself wherever you are, if you can. Okay, I'll leave that. I think that's it. You've done good justice to that topic, and your alarm just went off. So thank you for keeping also to time. On our second speaker, so she's going to be talking about depression in children and young people. And you can see the flow of events. So Kemi has spoken about depression. Our second speaker is going to narrow it down more in children and young people, and also touching on postnatal depression. We've got Dr. Tolu Oloyede. Dr. Tolu Oloyede is a consultant psychiatrist with over decades of experience working with children and adolescents. She's been trained in Nigeria and also at world-renowned mental health institute, the Maudsley. So you see that we're bringing you great people, we're bringing you professional people. Okay, Galaxy 803S, I see your hand. Just give me a second. She is a specialist in assessment and treatment of neurodevelopmental conditions, and she enjoys graphic design. Okay. I'm going to call you Galaxy A03S, maybe after Dr. Tolu has done justice to that topic, because you're still talking about depression, you're still asking on depression. So I'll call you afterwards for you to ask your question. So yes, please, over to you, Dr. Tolu, and thank you for coming.
Oh, thank you very much for your time as well. And thank you very much for inviting me. I'm going to try and share my slides in a minute. Just 1 minute. I'm going to try and share my slides. Just 1 minute. Okay. Share the slides.
So while we're waiting for that, if you've just joined us, welcome again. Please let us know in the chat where you're joining us from. And if there's someone that should be listening to this that you've forgotten to invite, this is your time. You can invite them now before we continue. Thank you.
Okay, thank you very much. I hope you can all see my slides now.
Yes, we can. Yep.
Okay. So I'm going to be talking about childhood depression. It's not a topic I particularly like to talk about, but it is a reality of our time that we have unfortunately, a lot of young people and even children suffering with depression. So a bit of background, and I think why this topic is very important for our time is because if you listen to the social media at all, you'll find that quite a lot of people are reporting increasing incidents of suicidal behavior in children and young people. I happen to know that in Nigeria, unfortunately, we have been having increasing accounts of children and young people, committing suicide. It's not so much a new thing, you know, in the UK or in the Americas, but I think it's quite a shocking thing, I find, that this is happening in Nigeria as well. So I think we need to go about and talk about it. I'm going to move on to my slides. So a brief introduction. First of all, childhood depression itself, it comes under the broad category of affective and emotional disorders of childhood and adolescence. So we do have, in psychiatry or in mental health, we have our classification manuals, which we use that helps to standardize how you diagnose mental health wherever you might be in the world. So those manuals, we've got two main manuals. We've got the DSM and we've got the ICD. Both manuals recognize that the condition called childhood depression. Now, when we talk about affective and emotional disorders, it's a very broad category, and it includes the following. It includes childhood depression, which I shall be talking about today. It includes anxiety disorders, adjustment disorders, post-traumatic stress disorders, which you must have heard about, PTSD, and obsessive compulsive disorder, OCD. But I'm going to be focusing on childhood depression today. So childhood depression, the prevalence rates. And by the way, when I talk about childhood depression, I'm talking about depression all the way from early childhood. We used to say in the past that childhood depression wasn't seen in children perhaps below the age of 6. We know that that's not correct now. So I think there are reports of depression as early as 3 years old. Unfortunately, this is happening now. So when we talk about childhood depression, we classify it into two main groups. It covers depression in children, pre-adolescents, and post-adolescents. So pre-adolescents will be about the age of maybe any age up to about 11 or 12, puberty, and afterwards all the way to the age 18. So childhood depression pre-adolescence, we're looking at the prevalence rate of about 0.5 to 2.5%, which some might argue is not too common, depending on the population, but I think it's a very large number for me. And this increases up to about 8% in adolescents. So the way to look at it is this, because sometimes figures don't really mean much, but it means that if you have 100 children gathered in a room that are pre-adolescents, you are looking at anything between one child, 0.5, or 2.5 children. There's nothing like half a child. So anything between 1 and 3%, 1 to 3 children suffering with childhood depression. And if you go on to post-puberty, you're looking at up to 8 in 100 children that would have childhood depression. And as I said before, childhood depression covers anything from childhood all the way to the age of 18. Now, the recurrence of depression, once depression has occurred, there is a great chance that it's going to recur again within the first 5 years of an episode. So it's such a high risk of recurrence of up to 70%. In children. And 50% of those children will go on to suffer depression even as adults. So even post-18, they will continue to have depressive symptoms. Now, after the age of 15 years, we find that girls are twice as likely as boys to develop depression. I think when Kemi was talking about it, she did mention that depression is more common in women compared to men. Now, I'm going to talk a little bit about the characteristics of depression. Now, childhood depression varies a little bit from adult depression. There are some things we see in childhood depression that we don't always see in the adult age group. The tendency for depression to develop more slowly in children compared to adults. So for children, we think that many times we deem their behaviors as being naughty or being difficult when actually they are quite depressed. We might see that there's a change of attitude towards family, towards friends, towards life in general. There might be a marked change in eating and sleeping habits. It tends to be more recurrent, like I have mentioned. So it tends to be, keep happening on and off and on and off. It tends to last from a few weeks to years, and it can be permanent. So it is possible to have a child that is depressed from the age of 8 and just keeps being depressed. Other clinical features that I want to talk about depression. I think Kemi has talked about sad mood. It's not just about a person being unhappy. She's also, telling the child, oh, snap out of it. Come on, get over it. That's life. We of the Afro-Caribbean heritage, we tend to ask our children to snap out of it. Come on, get a grip. Come on, move on. What's the big deal? Yeah, it's happened to you. Are you the only one? Are you the only one in the class? Are you the first person to fail an exam? Depression is not something that a person can snap out of easily. There is also anhedonia. Anhedonia means loss of interest or inability to enjoy pleasurable activities. So if you have a child that used to enjoy cycling, or used to enjoy swimming, or used to enjoy watching TV, and all of a sudden you say, okay, go and spend some time riding your bike. And the child is reluctant to ride their bike, or they just sit down, they don't want to do it, they don't want to watch TV. All of a sudden, they show no interest in things that used to really get them before. Then you might say that perhaps this child is depressed. Then there's a reduction in energy levels, feeling tired all the time. And sometimes the child or the young person might actually look unwell. Sometimes as parents, you take the child to the doctor, this child doesn't look well, doesn't look right. Does he have malaria? Does she have typhoid or whatever it is? You match the child off to the doctor, they do run all the tests and nothing is there. They're absolutely fine, no problem. Then I think at that point, one should be considering their emotional health and emotional well-being. There is also sleep disruption or reversal. So that's a situation where a child or a young person is awake during the night and sleeping during the day. Some might argue that you see this a lot in adolescents. When a child is about 13 or 14, they tend to not want to go to bed on time. But when the sleep is totally reversed, the other way around, there should be a cause for concern. Then there's loss of appetite, social withdrawal. Here you can find the young person saying that they are bored. We see that a lot. I'm bored. But actually, they're bored, but they're not making any effort to engage themselves in any activity. Then we also see impaired thinking, loss of concentration, and decision-making refusal. You ask, would you like to go to a party, or would you like to go and spend time with your friend? And they get quite distracted. What did you say, mommy? What did you say, daddy? I was asking you, would you like to go out? Oh, okay. I'm not sure. Maybe. Okay, let me think about it. That's sort of not being sure. A child that used to be quite confident to express themselves and say, yes, I want to go, or even will come to you and ask to go out, so suddenly not being able to make decisions about very trivial issues. Then reduced interest in schoolwork and reduced interest in achieving. A lot of young people want to achieve. They really would like to do well. So when they're not doing well or not even interested in performing or doing well, then there is a cause for concern. Then the combativeness with parents, that's when a child suddenly wants to fight. Everything is an argument. We also have to think about self-destructiveness. This we see a lot. When all of a sudden, it doesn't matter how hard or how much you talk to the child, they seem to be bound on doing the wrong thing. Truancy, no longer caring what happens to them. You say, look, if you do this, you are going to get into trouble. You're on the wrong path, and suddenly they're not hearing, they seem not to be hearing you. Delinquent behavior, getting into problem with friends, choosing to move with the wrong crowds. And lastly, recurrent thoughts of death or suicide. So when a child starts asking questions about death, showing more interest in death, about the afterlife, asking questions like, it might become quite subtle. a child might just come and say, what does it feel like? Mommy, do you know what it would look like if someone dies? What does it look like on the other side? You have an idea of what it looks like. Do people really go to hell? What happens there? I had a young person that had a lot of suicidal ideations. And the way this child manifested suicidal ideations was through talking about the afterlife, very fascinated about death and hell, would ask questions about hell. So what happens in hell? Is there really a hell? Okay, if someone dies, would they go to hell? How would you know that they go to hell? So, asking those sort of questions is a cause you might need to think about it, that what's actually going on in this child's life. Now, one of the clinical features, like I mentioned, is suicidal intent. We tend to call them suicidal behaviors because before the intent are the ideation. So suicidal ideations, when you have the idea about death, right? That can move on to suicidal behaviors, and then it graduates to suicidal intent, where you begin to, when a child or a young person begins to make the plans, and then finally the suicide itself. So the suicidal intent, it tends to be associated with a high risk of suicidal, but the clinical depression itself is associated with a high risk of suicidal intent, and a high risk of suicidal behaviors, especially amongst adolescents. One thing to take note of is for every fatality, that means for every death, there are at least 100 attempts. The suicidal risk is high in depressed boys, especially boys who have conduct disorder. All right, so conduct disorder is a condition where a young person violates social rules. So the way I can put it is, if you go to Nigeria, for example, a lot of, we call them the thugs and touts, and, some we call them the agberus. Many of them actually are clinically depressed. You just need to listen to some of the stories and you're not surprised that they are depressed. And you can imagine that, their risk-taking behaviors are quite high, the things they are ready to do. And of course, such people, they don't, when you see someone break a bottle and is not afraid to stab himself or to stab somebody else to prove a point, he knows that the risk of death is high. But many of these people are actually quite depressed. Now, amongst adolescents who develop major depression, about 7% may go on to commit suicide. That's a very, very scary figure, especially for people like myself who work in this field. The peak incidence of suicide is about the age of 15 years. And there are many reasons around that, which I might have the time to talk about later. Completed suicide in boys, it exceeds completed suicide in girls by about 4. So we tend to see suicide more in boys compared to girls. And the same we see in adults, more men tend to commit suicide compared to women. The commonest methods amongst the females is overdosing, wrist-cutting, while in males is gunshots, especially in the US. That figure is from the US, and then hanging. In Nigeria, I don't know what the commonest methods are, but I do know that there are some pretty scary accounts that we've heard about suicide in methods in Nigeria as well. Unfortunately, it is quite difficult to treat depression when suicidal ideations coexist. Now, the risk factors for suicide, I'm going to speed up a little bit now. The risk factors for suicide. In females, well, the first risk factor we should think about is, basically being female is a risk factor for suicide, especially suicidal ideations. Being male is more of a risk factor for completed suicide. Suicidal ideations, major depressive disorder, substance abuse, antisocial behavior, undesirable life events, things that you didn't hope for, plan for, wish for, think of. Those things can increase the risk of suicidal ideation and attempts. Problems with parents, school, loss of employment for young people. In this country, We have young people starting work as early as 16. And sometimes, you know, if they lose the job, that might be a cause for suicide or suicidal ideations. And then sexual or physical abuse, again, is something that is a reality of our time, unfortunately. Completed suicide, it's males, previous ideations or previous attempts, a family history of psychiatric disorder, completed suicide, mood disorder, alcohol or drug abuse, antisocial behavior, acute life crisis, and disciplinary problems in the last year. So when I talk about disciplinary problems, you can think about people who have had problems with the police or with the criminal justice systems. You know, that increases the risk for a completed suicide. So this risk sometimes can be cumulative in the sense that if you have a male child who has a history of a family history of psychiatric disorder, who uses drugs or alcohol, who has gotten into the wrong crowd, who has had disciplinary problems in the last year, the risk for completed suicide is much, much higher. This is something that we don't like to talk about, but it's also a reality of our times, sexual abuse. And the fact that boys could also get sexually abused. And I think we know more about females getting sexually abused, but boys, not a lot is known about what happens to boys. At least I think in Africa, I'm not sure of how much is known, but I know here it is a big issue and a big topic. But just to mention that the risk of suicide is 40 times high in boys who have been sexually abused. So it's very important that as we're guarding and safeguarding our girls, we're also doing the same for our boys. Now, warning signs for suicidal behavior. I thought about this because I said, of course, it's a topic that worries a lot of people. The short term, expressing thoughts of suicide as a solution to problems. You know, when someone is saying, it's better I die, or don't you think it's better I die just so that I can get out of this problem? References to suicide in conversation, disciplinary crisis, e.g. when a child is expelled from school, when they begin to write, and what I've seen a lot is they don't write so much, young people, what they do is they draw. You know, they draw pictures of death, they draw pictures of coffins, of hell, of grave sites. Also increased help-seeking behavior when they start asking for help. These are short-term warnings. And sometimes improvement in mood just before they begin to carry out the act. Long-term warning signs are psychiatric morbidity. So when there are psychiatric, other psychiatric problems, recent losses, hopelessness. Hope is a very, very important thing in a young person. And that's one of the key things that we as the adults should try to instill hope in children, instill hope in young people. You know, for example, the country, Nigeria, I know because I'm Nigerian, I know about Nigeria, there's a lot of hopelessness in the country about how things will ever get better. Even in the UK now, with the economic crisis, things going badly, there's a lot of hopelessness that young people are expressing. You know, would I ever be able to buy my own house? Will I ever be able to get a good job? Does it make sense for me to study? Why don't I just go into anything? Because it doesn't make sense to stay in school. You know, we have a responsibility to instill hope in young people, because hopelessness is one of the signs of suicidal behavior. Also, academic and general underachievement. When young people are not doing so well in the academics, but it's not just academics. You know, there's a whole lot of stuff to life rather than just the books. You know, underachievement, when a young person feels that their peers are, you know, doing so much better than them in other areas of life, you know, this might be, if they hold on to that belief strongly enough, this might be a warning sign of suicidal behavior. And I think I also want to mention social disadvantage as well. Specific presentations, I'm just going to gloss over this. So childhood depression can be associated with psychotic psychosis. And that's when depression also manifests with loss of reality, right? So the child or the young person is depressed, but also they've lost touch with reality. So that's when we call it psychotic depression. They might present with delusions, with hallucinations, that seeing things that are not there or hearing things that are not there, all right? And then they have these delusions, just very self-critical or self-punitive content. So, for example, they might be saying, an example of auditory hallucination that is of depressive content. They might be saying, I'm hearing a voice telling me that I should run into the middle of the motorway so that a car can hit me. I'm hearing a voice telling me to hang myself. Every time I sit in the room, I see someone coming that wants to, that is trying to kill me or to stab me. Or I'm hearing someone saying that I should set the house on fire. Those are very depressive content, and it's a sign of hallucinations, of psychotic depression. Then also there's bipolar affective disorder, and that's when the low mood or depressive condition is associated with irritability, excitability. The person one day very depressed, the next day they are excitable, excess energy. But also associated with this is loss of judgment and disinhibited behavior. That's where a person is crying, but at the same time, they might be stripping themselves of their clothes and wanting to, sometimes there's sexualized behavior associated with their presentation. As I said, these are specific presentations, and I don't want to go too much into this. Now, the risk factors for childhood depression, generally, I think for the large part, this is still an area that we need to study a lot. There is still a lot of work to be done around understanding childhood depression. The causes are unknown in most cases, that's the fact. But evidence shows that there's a change in the concentration of neurotransmitters in the brain. So this goes to show that depression is not something that a child or a young person puts on, right? It is a real condition because research has shown that the neurotransmitters change, but also neurotransmitters are the neurological, what we find in the brain that keeps the brain moving. And sometimes you also find that the children with the childhood depression, there are structural changes also in the brain, okay? So other risk factors, I've mentioned some of these before, biomedical factors, a child being female sex, hormonal changes during puberty. So we see a lot of young people being depressed just around, especially females, just around the time they start their menstruation. And sometimes some children have to be placed on oral contraceptive pills, not for the sake of contraception itself, but used for mood modulation or mood moderation. So also chronic illnesses. When a child has chronic diabetes, mellitus, when a child has maybe asthma, because these are conditions that might limit a child's access to enjoying life or doing things that they want to do. For example, I had a young person that presented with depression in the context of severe asthma. So wants to ride, wants to go and play with their friends, but the parents say, no, you can't go because of your asthma. We don't want you to have an attack while you're out there playing. And of course, it led to depression. Then parental depression or family history of depression. Many people don't ask the question about, family having history of depression. Chromosomal abnormalities, genetic problems, and of course, use of certain medicines. So medicines like, sometimes medicines used to treat acne can cause depression. Other factors are psychological factors, intellectual disability. A young person that has an excessive sense of responsibility for others. We find that a lot in Africa. You are the firstborn child, you are the firstborn. You have to look after your sisters. You have to look after your brothers. You have to be responsible. You have to take charge of the house if I'm not there. So we find this happening a lot to, children being given a much more responsibility than they are supposed to carry. You find an 8-year-old carrying the weight of the house because they are the first child, Then excessive sensitivity, ego, vulnerability. Some kids are just sensitive. We have to be careful about that. They are just born that way. They're just very sensitive children, and some kids are born with low self-esteem. Sometimes it's body image. If a child maybe is too skinny or too fat, or maybe short, or maybe not too tall, something to do with body image, psychological factors can lead to childhood depression as well. So as parents, we have to be careful about how we give our children confidence in how they look and who they are. Psychosocial factors, childhood neglect, abuse, socioeconomic deprivations, loss of a loved one, war and social instability as well. So we hear of the wars happening all over the world. I think most prominent now is Ukraine, although we know there are wars other parts of the world. There's war there's an ongoing war in Yemen. It's been going on for many, many decades. So these children that grow up in this sort of situations are more likely to have depression. Then I mentioned here bullying. Please, parents, pay attention to children, because bullying can cause depression. And a lot of children are bullied at school. Parents, you need to listen to their children so that we can, and also address bullying when it does occur. It is a risk factor for depression. Other factors, I'm just going to gloss through this. I think the only one I want to pick up here is cigarette smoking. Of course, we don't advise children to start smoking. It can cause depression. But not just that, parental cigarette smoking around children can also lead to, can be one of the causes. There's no causative, it's associated with, I won't say there's a direct causation, but it's associated with childhood depression. Then there's also ADHD, but I don't want to go into that today. Now, childhood depression is often underdiagnosed, because I think even though I'm in the field, it's not something I'm quite unhappy, or I'm quite reluctant and careful to diagnose it in children. So we think it's probably underdiagnosed in the world, probably in Afro-Caribbean countries, even less diagnosed. And it could be because there's this reluctance to stick a diagnosis of depression on children, but it could also be that children themselves or young people themselves might find it very hard to express how they feel. And it might be that we find it easier to just stick on conduct disorder or behavioral problems on children rather than face the emotional problems that a child might be facing. Also to note that other co-occurring conditions can mask depression. Now, differential diagnosis there are lots of differential diagnoses. Anorexia is one of them. Epilepsy, traumatic brain injury, adverse drug reaction, psychosis, substance misuse. And then I want to talk about management quickly. I'm not going to go into psychopharmacology because I know one of my colleagues will be talking about that. But one of the things, just briefly, I'm going to touch on these briefly. The important thing to note is that depression is treatable. It can be treated. And there is hope, especially when it happens in children, there is hope. I've seen children recover from depression. I've seen children go on to live their lives really well following an episode of depression. But there are things that need to be put in place. Some of the interventions are school-based. So depending on what the causative factors are, it might be that, some interventions being put at school. For example, if a child has intellectual or learning difficulties, they might benefit from special education needs, attention from school. Then psychosocial therapies, helping the child to relieve their symptoms through resolving their interpersonal problems. So if they're having issues with their friends, you might have to step in and see how you can help them to solve those problems. Helping children to adopt mature defense mechanisms, a realistic sense of self. So for example, you fail an exam does not mean that, you will fail all the exams for the rest of your life. People who are depressed tend to, over catastrophize issues. So helping them to know that, look, you don't have to catastrophize it. There are solutions and sometimes practical issues, practical solutions. How do you address the issue at hand? You failed an exam. Okay, what needs to happen? Do we need to get you a teacher? Do you need to revise some more? Do you need to repeat a class, for example? Do you need to drop some of your the harder subjects for GCSE, take a simplified? Do you need to drop a grade? Whatever it is, there are practical solutions. Then you might need to resolve past traumas, and also encourage avoidance of, encourage children, especially the young ones, to avoid alcohol, illegal drugs, sleep deprivation. That's a very big one that we see a lot in our youths, especially with this age of gaming, wanting to game till midnight to 2 a.m., spending time on their phones. This sleep deprivation can lead to depression. Then academic work, supporting them with academic work pressures, and also helping a young person and even parents to understand, to realize that pretending that nothing is wrong does not help. Family therapy, yeah. So I don't know how much of that we have in African countries, but here, family therapy helps. Positive reframing within the family, decreasing blaming and scapegoating. One I really hear about is, oh, it's because you are like your mother, that's why you are like this. It's because you are like your father. Recognizing cultural issues as well. So I think my time is gone, but just the summary, as depression can occur in children and young people. Depression is a mental health condition, but often goes unrecognized. It can manifest in many ways, but it is important to look out for changes in mood, behavior, eating, and sleeping habits. And it's often associated with anxiety, but it can be treated. Thank you very much.
Wow. Thank you so much, Dr. Tolu. That's fantastic. Let's give our hearts, please, virtual hearts, to say thank you. We are over 75 now. That was just fantastic. That was really good presentation. I found it very informative and very interesting at the same time. So I've got a question for you. The first one is person says highly educative program. How can you motivate young ones with Nigerian system of education with a lot of strike?
Okay, so that's a very good question. I think one of the things I said was it's instilling hope, right? So when you say a lot of strike, for example, you're talking about young people in university, isn't it? Who have started, who have started, because I know that there's an ASU strike going on again. I think that's still ongoing, isn't it? So, a young person goes into university with all the excitement. I'm just trying to remember when I went into university, all the excitement of being a fresher, and then within a few months, the university goes on strike. But I think the important thing as parents, as families, is to keep on encouraging young people and to use the opportunity they have. During my own strike, I think we had I don't know whether we've had anyone that's beat it, because we lost a whole year in my time. It was a full year at home. But during that period, one of the things I did, or one of the things I was encouraged to do, is I started a little business at the time. All right, learn something, take it on, but learn sewing, go and learn how to barb hair, go and learn how to do things. You might think that it's nothing. There are lots of people that come to the UK and making a lot of money from this, things that they use their hands to do, making more money than a white collar job. Go and improve your skills around computers. Go and improve your skills around, if you're into social media, improve your skills on it. Don't just sit at home and be miserable and, do whatever you can. Help your parents. Take it as an opportunity to help your parents. Get a little job on the side until school starts. That's what I think. Thank you.
Thank you. If you can just stop sharing first before we go to the next one. Thank you so much. Yes, and I really want to buttress that, because that was how I learned to be in a computer school, which is what I'm now doing anyway professionally. it was all as a result of strike here and there. So I took a year, and that's it. So the next one is, how do you instill confidence with a depressed adolescent? I'm thinking that would probably be, how do you instill confidence with a depressed adolescent? Do you want to stop sharing, ma'am, so we can see your face very well?
Okay, yeah, I will do that now. Okay, thank you very much. So now I think the first thing is, I think it's a good thing that's been recognized, that that the young person is depressed. That's the first thing, recognizing that there's a problem. And instilling confidence, what is making the child not confident to start with? So there are still a number of questions to ask around why the child is not confident, why the young person is not confident. Is it the background? Is it family? What is going on? So I think one thing I find is that a lot of parents don't really know their children or what's going on in the minds of their children. And it's taking that time to actually find out what the problem is, because it might just be a very little thing. I've seen children who are depressed because of the clothes their parents, you might think it's a small thing, but trust me, in the society I live in, it's a big deal. So you might think to yourself that, well, I can only give my child what I can afford, isn't it? But if a child goes to school with the wrong set of clothing and they become a target for their peers to make fun of them, okay, and they begin to be subtly bullied, you'll be surprised what happens afterwards. It can lead to other issues. So it's about finding out what the causative issues are. What is knocking down the child's confidence? Are they overweight, for example? Is that the problem? Is it that they're not very bright? They're academically underachieving. Whatever the issue is, it's finding it out and being solution focused. I think that helps with the children. And sometimes it also, psychological therapies help, because the reality is sometimes our children will not talk to us. They will talk to the third party, but they wouldn't talk to you. They wouldn't talk to the mom. They won't talk to the dad, especially if a child has never learned to have that sort of relationship with their parents. They might find it easier to talk to a third party.
Thank you so much. Someone says, thanks, Dr. Oloyede, really informative. Another question. Thank you for an excellent talk. Would you like to comment on the impact of social media on childhood depression?
Thank you very much for your question. Now, that is a big, 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 big one, because let's face it, social media is a good thing. We're using one of the, mediums, but the issue is social media it has its positive aspects, because I'm just thinking of the things my children, help me and teach me and show me. But also the negative is that there's a lot of, shall I use the word, misinformation on social media. And the young minds we have tend to believe everything they see or everything they read. We have that experience also with adults who, there was one, it was quite a disgusting picture of, something about, I think a cat giving birth to human beings or something like that. It was some picture someone sent me some time ago, and the person who sent it believed it. And I was like, have you heard of something called Photoshop? I can Photoshop anything and post it, so it's about helping children to be quite mindful that not everything on social media is right. Not everything is, even if it were right, not everything on social media should be consumed, right? Even for adults, it's not everything on social media that is for me to read and to assimilate and to consume. So what happens a lot is children read on social media and they believe what they see. They believe that, it's possible. I think it was last year or so, there were children who committed suicide because there was this whole tournament. I think it was Fortnite or something. I'm not very good with the gaming world. It was a Fortnite or something, and then they didn't win the £1 million that they were promised or whatever it was, and then they decided to end their lives. So not everything is right. It's not true. It was a lie. It was a whole campaign. It was somebody who sat in their room doing a fake campaign. And the children worldwide believed it, right? So that's one issue. The other thing is on social media, for example, body image. You know, there's this thing about body image, you know, people looking slimmer. The latest we see is people having this, especially young girls, having this very fantastic figure 8, you know, very well curved, you know, or young boys having the 6-pack, the muscles, and looking so good, you know. And then when a young person who sees that is trying to achieve the same thing and they can't, then they begin to feel this low self-esteem, you know. So it's about helping children and young people to have realistic expectations. And if the children are younger, parents, it is our responsibility and our duty. And the children don't have to like me. Like I always say in my house, you don't have to like me. I only have to do my job as a mom. You need to monitor and switch off whatever you don't want them to have access to. Monitor it. If you don't want them to have access to it, please turn it off. Put the blocks on it. Get a savvy person. I'm not very savvy with internet, I must say, but get someone who is savvy, who knows about the blocks and all the, I don't know what they call them in computer, whatever, to put the blocks on the phones, put the blocks on the internet, switch off phone at a particular time, and that's it. But also parents, if you are going to set rules, you learn to follow the rules yourself because children are always watching us. Thank you.
That's so excellent. Thank you so much. Yes, well done, Dr. Tolu. Great presentation. Got loads of hearts. Great presentation, Doctor. I'm just trying to read more. Thank you, lovely presentation. Question: is depression and mental health the same thing?
Oh, thank you very much for that question. So mental health just is a very huge umbrella that covers a whole range of things. So depression is a form of a mental health problem. That's what it is. It's a form of mental health problem. So there are all sorts of mental health problems. In fact, depression is also a subclass. It's a subclass of what we call affective disorders. So under affective disorders, we also have anxiety disorders, which is another big class. So yeah, depression is a type of mental health condition.
Okay, thank you so much. I'm just going to read one more question for you, and then we'll move on, and then we'll take the rest of the questions later. Someone says, if you must set rules, I think this is for everyone, learn to follow them. That's a word on Marble that got me. The last question is this: when a child is bothered with insomnia and refuses to accept that it's depressed, what do you do? Or how can you convince the patients? Thank you, ma'am.
So insomnia itself is a condition. It's a medical condition. Insomnia means inability to sleep. And it's one of the symptoms, like I said earlier, it's one of the symptoms you might see in a depressed individual. So it's, in fact, we see it quite a bit in children, but not necessarily children who are only depressed. It could be associated with anxiety disorders. It could be associated with fear to sleep. So it's very important that insomnia is assessed. A proper assessment needs to go into insomnia. What is causing it before we say it's depression? Because depression, as I said, it's one of the symptoms of depression. So you need to take that child to the doctor, or that young person doctor, and assess what is causing the insomnia. But what we see a lot these days is that we have what we call self-inflicted insomnia in children, where they refuse to go to bed because they're on their phones. It's not that they can't sleep, it's because they don't want to sleep, because whatever they are watching on phone is more interesting than going to sleep. You know, so you see kids on, you know, I don't know all the names of this, you know, Snapchat or whatever it is, or YouTube or whatever, or WhatsApp, you know, till very, very late at night. But the issue is we need to help children to understand that sleep is a vital, important part of their mental health and emotional health. If you don't sleep well, you don't develop properly. especially for children, they need to sleep. If a child isn't sleeping, it's a very, very serious thing. I'm sorry, parents, it's a serious thing. Children need to sleep because it's the time when the brain has the opportunity to rest. It's the time when the brain has an opportunity to consolidate learning and knowledge, all right? And to filter what's important and what's not important. So we often see children who are not sleeping develop behavioral problems and can go on to be depressed as well. So it's important that you find out what on earth is causing this child not to sleep. So it could be a primary insomnia, which is just a child who can't sleep. So it's in my current role, I see children with complex neurodevelopmental conditions. And these are children that it's through no fault of theirs, their genetic makeup means that they can't sleep. But that doesn't mean that the fact that I know that they can't sleep, that they don't need treatment. We treat them. We absolutely treat them because sleep is so vital. But if a child has a secondary insomnia where they are not going to bed because of their phone, if you need to take away the phone, you need to take away the phone. But the thing is that I always say this, children watch us as well. You can't seize your child's phone, put it next to you, and then you are on your phone. You can't say TV time, no more TV, and then they see you watching TV till late, right? Because when you're trying to set rules, you have to learn about family rules, which helps children. They adapt better when they know that, oh, everyone is doing the same thing. Family rules. I had a family where the phone was a big issue for the children. The dad said it almost killed him, but what he just decided was, okay, everybody, 9 o'clock, he had this little tray. Everybody puts their phone in the tray, everybody submits it, the children go to bed. He said when they are fast asleep, he knows they are all asleep. He can now go and take his phone and start doing whatever he needs to do on his phone. But the children could see him. It's called modeling, putting the phone in the tray. So if your father, the father of the house, is putting his phone in the tray, then tell me how a 10-year-old come and say, Daddy, I want to be on my phone at 8 o'clock. It's not possible now. So this is the thing you have to think. Insomnia is not a thing to joke about with, please. Then avoid things like fizzy drinks at night. People don't know it. A lot of the fizzy drinks, Fanta, Coke, all these things carry caffeine, which keeps children awake. So no fizzy drinks in the night. Some drinks like orange squash, some of them have we call them the E group coloring. Those can make children quite hyperactive and prevent them from sleeping. So there are many things.
Sorry, Dr. Tulu.
Yeah.
I think we're going to stop there just for the sake of time.
Yes.
And I know you're still with us anyway. So if you have questions for Dr. Tulu, I think I've got 3 more. I've saved it, and we will have it at the end of all the speakers. She's still here, very much here with us. Got 80 people now in the group. Thank you so much if you're joining us for the first time. If you haven't tell us where you're dialing in from virtually, if you want to put it in the chat, you can also follow us on IG or YouTube on Encapsulate Health. Okay, so thank you so much, Dr. Tolu. So informative, so good, too good. The next speaker, like I said, is a progression. So we've been looking at depression. And so we had looked at depression as a whole. We've looked at depression in children and young people and postnatal depression. The third speaker is the host herself. She will be looking at depression in the elderly. So I've got Flora Coker. Flora is an award-winning pharmacist with 21 years experience in various sectors of pharmacy. Her main specialty has been mental health. She is the founder of Encapsulate Healthcare Solutions, which is where we are right now. Sorry, I think I've lost myself there. Can you see me? Can anyone see me?
Yeah, I can see you.
Okay, perfect. She is a lover of Christ, and her passion is helping people to improve their lives and that of their families through health education. And thank you for saying yes. As a result of your yes, here we are today. So I'm just going to give it to you. If you can just start sharing your screen. Thank you.
All righty. Thanks, Bumi. Thanks, everyone, for hanging on in there. I'm going to try and be quick because the time is running away from us. Like Bumi said, yes, mental health has been my specialty. And a couple of years ago, I realized that in our community, we did not understand what could happen as our parents get older in terms of their mental health, specifically depression. And so that's why I'm going to be talking about that this evening. Let me share my screen. Or have I got YouTube on here? Okay, here we go. Right. Right. Can you see that? All good? Bumi, I can't hear you if you're replying
Yes,
me.
very good. Yeah.
All right. Okay. So, depression in older adults. I'm Flora Cook, as we've just said, and let's go. Depression in older adults. It's a major health problem. It's not a normal consequence of aging. As we said, it's a form of ill health. Elderly adults who are from racial ethnic groups show a particular vulnerability to some common mental health illnesses, including depression. Now, research suggests that older Blacks, they bear a higher burden of the risk of depression. And this has been found to be rooted in social and medical disadvantages. They might be living in poorer areas. They might not have good social networks like other groups may have. Research has also suggested for older Black adults that they have a higher incidence of dementia, and preventing depression may delay or prevent dementia. So that's research that's ongoing, but that's what we know so far. Also, inequality in utilizing accessing mental health services, or just healthcare services in as usual, in general, and the treatment rate of depression also, as a result, is not that great. They're not being detected because they're not going. Nobody's seeing them, so nobody's diagnosing them with the mental depression with depression to help them. So that's another issue we find in elderly patients with depression. Okay, now it's common in older adults. 1 in 5 may have depression. It's associated with disability, increased mortality, also known as increased death. Also, poorer outcomes from physical illness because of perhaps isolation from the illness, the chronic illness. I think Kevin mentioned it earlier when we were talking about chronic illness. It's under-recognized, like I've just mentioned, and of course, it's under-treated. Now, depression can severely affect the quality of life of elderly Black people, and in turn can adversely affect their physical health. The World Health Organization suggests that proportionally more people over the age of 65, commit suicide. So it is an issue which we need to be more aware of and perhaps start tackling. Now, types of depression that elderly patients may. Oh, I've got the admission thing coming up on my screen. 1 second. Okay. So types of depression that we may find in elderly Black people. Now, this information is from the National Institute of Aging in the US. So they define major depressive disorder, again, which is what Kemi described. It's the same definition in older adults. Symptoms lasting at least 2 weeks that interfere with the person's ability to perform daily tasks. The older Black adult may have what we call dysthymia, which is a persistent depressive disorder. Now, in this situation, the depressed mood lasts for more than 2 years. It can last for more than 2 years, but the person is able to go about performing daily tasks, unlike someone who has major depressive disorder. So that's the difference. In older Black adults, there might be issues with substance abuse. It could be medication induced as well. And as we've mentioned several times, depressive disorder could also be due to a medical condition, separate illness completely, like heart disease or multiple sclerosis. Okay, so what are the causes and or risks of depression in older people? You could have biological causes, a family or personal history. It could be genetic. People who have a family history of depression may be at higher risk. Health problems, like we've mentioned, the chronic health conditions. Again, you could have depression after stroke. We have a condition called post-stroke depression. We know that occurs. In patients who have cancer as well, it can occur. Physical, psychological causes, fears of the future, bereavement. They may have experienced bereavement, and of course, during the pandemic, that has been a major issue. They could also have sleep problems, poor sleep, just like Tolu just mentioned. As it's a problem, it can be a problem in children, it can be a problem in older adults as well. Social isolation and loneliness. That is a big issue. We've just had Mental Health Awareness Week here in the UK, and the theme was combating loneliness. Loneliness is not a good thing, and I don't think we attribute enough importance to it. Loneliness and isolation is a big thing. Okay, so they may also have functional limitations that it makes them engaging in activities of daily living difficult. For example, if the older adult, maybe they have arthritis in their hands, they're not able to open cans easily, they're not able to, mobilize at open doors or open cupboards or things like that. So that could be an issue. Addiction or alcoholism, again, can be a cause or risk for depression in older adults. In a 2012 study, they looked at the correlation between depression and the elderly, and this study was actually done in Lagos. And they found that the older adults who were more at risk of depression had low social support. They were living in less developed areas of the community where they were, and they had been living in their current residence for a very long time. They didn't state how long, but a prolonged stay in their current residence was found to be a risk factor for depression. But on the other side, they found that adults who had high social support were less likely to have depression. Another thing that they found was older adults who did not have any children were also at risk of depression. Okay, so now, how is depression different in older people? We've heard how it is in children. How is it in older people? There's tend to be less verbalization, less expression of how they're feeling. There's a denial of depressed mood. They may be preoccupied with physical symptoms. 65% have hypochondriasis. Hypochondriasis is the distressing and excessive anxiety about your health. So an excessive worry about your health. So depression may also present as a new medical complaint or an exacerbation of current complaints that they have, e.g. the arthritic pain. Medical conditions can mask the depression. We've mentioned that it can cause, but it can also mask. It can also manifest as cognitive impairment. There may be an impairment in learning things, in their memory, in their thinking. Their thinking may be much slower than before. Slow speech as well, with long pauses before they answer. Slow body movements. I know Kemi mentioned that earlier. In depression generally, but in older adults, slow body movement. This is called psychomotor retardation. They could have more weight loss. They might be more anxious, and they might be more agitated. And we might not pick it up and think, okay, this might be something to do with their mood. They might be more agitated or more irritable. They might have decreased energy. They might be more tired more frequently. They might have difficulty concentrating and remembering, or even to make decisions. So this is how depression may manifest in older people. I've mentioned about suicide being more frequent in over 65s. Okay, I'm going to stop sharing. I'm going to ask the question, why doesn't this population seek help? What do we think? I want us to share ideas. We've been talking to each other for a long time. I want you to talk back at me now. Why do we think in this population they don't seek help? They might not want to seek help. Anyone? Just put your hands up and let's talk.
I think I've got someone reply. If you can put your hands up, please, then I would unmute you.
Yeah. Why would they not seek help?
Adesheluka Yetunde says it is a really big challenge for older adults in Nigeria here, because of many of our older adults are abandoned by their children due to varied reasons. And Amaka says that's a shame.
No. See, because of shame, that's the reason they might not seek help. Yeah. Okay, Elizabeth has her hand up.
Elizabeth, I've unmuted you. If you can someone says stigma as well.
Yep, that's correct.
Elizabeth, I've asked you to unmute. If you just unmute yourself.
I'm saying stigma and poverty can also be a result why they are not seeking help. Stigma and poverty.
Stigma and poverty. Thank you so much.
Yeah.
Okay.
Thank you. And I've also got shame and stigma, or maybe they don't know where to get help. And someone also says self-denial.
Yeah.
Self-denial. I'm going to ask the next person, E or Trofan nowhere, to please unmute and talk. Okay, I can't see that person anymore. Okay, we've got Henrietta. The older adults may not want people to look down on them. I think that still all comes to shame, stigma.
And the stigma.
Loneliness.
Yes, like I mentioned.
Loneliness. Ola F. Jewelries, if you just unmute yourself, please.
Okay, I think one of the reasons people might not also come out is they may not be able to find the appropriate words to describe it. Because awareness of a medical condition can bring to your attention that you have this problem.
Yes.
So, yeah.
Thank you for that.
Thank you. I've got Adeshe Luka. In Nigeria, we don't have facilities, opportunities where they can seek for help. It's a really huge challenge.
Okay, is it that they don't have opportunities, or because of the shame, they don't seek the opportunities that, but we'll come to that.
Olabode Daramola says the next big thing in Nigeria will be old people's home. Our youth are exiting or leaving their parents at home. I think, I think that's already in place anyway, but I'll leave the professionals to talk about that. And Henrietta says ignorance can be another factor. And
Absolutely.
I've got Baroness V, if you can just unmute yourself and share your thoughts.
Okay, I think some of my thoughts have actually been mentioned about stigma, shame, and self-denial. And I think that's because up until recently, mental health was actually, should I say, looked down on? And because if you have, it's written down against you, sort of. If you have mental health, in some cases, your children are taken off you. In some cases, you might not get a job. Do you understand? So those type of things actually prevent people from coming out. However, things are changing. Awareness is coming out. People are coming to, speak out. There's this campaign now saying even the royal family are also on, just to encourage people to speak out and also encourage their neighbors to actually help to make sure, so I think that's the main thing that keeps people, because I have a friend, I mean, she's just been diagnosed with mental health and she was just saying, oh, does that mean I won't be able to work? And this is actually just recent. Do you understand? So for someone like that, would she want to go and ask for help? I don't know.
Okay, so with that example you've given, Baroness V, that's a younger adult, and if she's based in this country, it's actually illegal to discriminate against someone who's got mental health if they want to work. But specifically for the older adults, like you said, a lot of the thoughts that you were going to share have been shared. That's right. Thank you. Bumi, you're on mute. Okay, Dr. Salisu. So unmute yourself and make your comment.
Okay. Yeah, good evening to everyone.
Good evening.
Just want to add the reason why is most cases they've given up is to have them around me. I think most of my sisters have tried to dump most of my elderly ones to me because they can't even endure the complaint and everything. So it takes somebody who is very patient and understand the kind of workshop or the kind of webinar you are attending to handle such cases, to be patient with them, to listen to them, share a lot of mental health tips with them. So in most cases, they feel, oh, this person cannot handle my situation, or this person can, so they give up easily. That's just my little contribution from my little experience. Thank you.
Thank you so much. All right,
When
Dr. Herrera.
Low self-esteem and the victims will not want to be seen as failures. Absolutely. In Nigeria and cultural norm. And then we've got what can we do to help our older adults? I think we're going to come to that.
We'll come to that afterwards. Let's just get
for me, because when I visit and I see people and provide them food, it makes me so unhappy seeing them alone in their homes with no food and no help.
We'll come to that. Let Dr. Orire just make a
Yeah,
contribution.
I've already unmuted her.
All right.
You need to accept now. If you just accept.
I think you might be both pressing it at the same time.
Okay. Yes, yeah, I'm unmuted now. Yes, we can.
Yes.
Can you hear me?
Yes.
Hi, good evening, everybody.
Good
Sorry
evening.
for all the drama. I'm on the road, so I think sometimes my network is not connecting properly. Well, thank you very much for your talk thus far. I think I may have been late, but just to contribute to what Flora has said, I think for the most part, in addition to what a few other people have spoken about, I would still say ignorance. Ignorance where the elderly are concerned. Ignorance, I'm speaking from Lagos, Nigeria. I do agree that awareness is increasing. However, it's increasing in a sector of society, those who maybe have a bit more exposed, a bit more educated, have rubbed shoulders with other people. There is still a lot of ignorance as to what exactly is this patient feeling. Well, the patient is not the patient until it comes to the doctor. But what exactly is this elderly person feeling? What are we, in what context are we putting it? Because it's almost like as you get older, there are some things that you can't do, so don't even bother. So there's still ignorance on part of the patient suffering the problem who easily accepts that, well, this is how the people before me were. And then the caregivers, be they paid caregivers or relatives who feel like, have I not given you money? Is that not enough? Thinking that money can fix it. And sometimes it starts very innocuous, very, very gentle, you know. That's this whole idea of being a bother to the people who have a life and they are moving about their business, and I'm not so needed in society. Society can start simply from the home or from maybe your church or where you will ordinarily go and become. And then they see themselves reducing in significance. Remember that you want to be somebody. You want to feel wanted, you want to feel needed. So there is ignorance, sort of. So it's not like you're a dull person, but not actually understanding these are the changes that are going on and putting them in context and seeing how we can actually start to, who should we talk to? It's still ignorance. If you don't know you have a problem, chances are you're not going to try to even address the problem, talking of who should address the problem. So I would say a lot of ignorance. And what we're doing, if we can't spread it, if we're still limited to those who are like us, we might not actually be getting there, because the people who don't know are much more than those who know. How do we spread this ripple effects? That's my opinion. Thank you.
Thank you so much, Riri. Thank you for that. Well, most of the reasons that people don't seek help, you know, have been mentioned. Looks like you guys were reading my papers. But some of the other ones that have not been mentioned, cultural beliefs, I thought that would be actually very high. For example, there was actually a research study that looked into this, and the reasons that came up were cultural beliefs. Why do I need to tell people my business? I just need to get on with it. Like Tolu was saying, it's not just about getting on with it, it's a serious illness. What else? Mistrust of healthcare professionals. And I think that might be a major one in Africa. Mistrust of the healthcare professional. Like with spiritual beliefs. I thought someone would mention that. They don't believe that they're ill. They don't believe they cannot be, you know, they cannot be ill. That's another reason why people do not seek help. So we've said a lot of reasons. And as Iriri said, what do we do next? Like Yetunde is asking, how do we help the older adults? I will leave that thought. I will deal with it at the end because I'm conscious of time and we need to move on. So that's me. So Bumi, we can go to the next person. But please remember, we need to discuss that at the end. Thank you.
Just on that note, I think one of the ways we can help is if you just kindly share this on your social media platforms. One way you can help is just to make sure that this information that we're sharing goes far. How can somebody know what they're doing wrong if there's no one to tell them? So that is what Encapsulate is doing. We are unlearning and we are relearning some things. I've learned a lot, like I always say. So if you have a social media platform, maybe you want to share the YouTube link Like I said, the YouTube page is Encapsulate Health. Maybe you want to tell somebody, another colleague, invite them and tell them, look, I'm listening to something very important here. We're talking about various things. And if you please want to join us. Okay, before I go to the next person, can we all drop a heart for all of our speakers, please? If you're here, I want to see it in the comments. I want to see virtual hearts going up. Let me know that you are there. It's good to hide away when we are here. I've only seen 2 people out of 76 here. Just let's drop a heart. Let's drop them love, whatever it is in the chat box. Thank you. Keep dropping it. We see you. Thank you so much. And in that order, I would like to call on my 4th speaker. Actually, yes. We're going to talk about a charity initiative that Encapsulate actually supports. Okay, we support charities. We're going to be talking about this charity initiative, and I would have the host person herself, Flora, again, to talk about it and to introduce the guest speaker for this charity. Thank you.
Okay, so the next speaker is Yetunde Adesheluka Oladejo. How did I meet her? I met her on LinkedIn actually when she was posting about her charity and what she's doing, and I thought this is just amazing and it's something that needs to be supported. When she speaks, you'll understand why. As a woman, it's very important. So Yetunde, where are you? Just raise your hand so we can find you and then unmute you. I'll let her talk more about the charity. I promise she won't be long. I know the time is running. Yetunde, where are you? I saw you on here just now. While we're waiting, if you want to walk around and get some exercise.
Yetunde, I can see you, but if you just put your video on, if you can, so it's easier. I've asked you to unmute.
I hope it's not her network. If not, when she's ready, we'll come back.
If you're ready, just send a message to myself or to the host that you're ready, and we would get back to you. So moving on. Now I've got the speaker who is just going to talk to us about anxiety. I think somebody already mentioned anxiety in the chat. So we've got Ebenezer Oloyede. He is a qualified pharmacist for 5 years. He's currently a principal mental health pharmacist and a PhD candidate. He must be a very brilliant person. Okay, Ebenezer enjoys exercise and food, and you can tell he loves exercise and food. All right, so we'll just welcome to Encapsulate. There you go.
Thank you very much. Thank you for the introduction. It's a pleasure to be with you guys this afternoon or this evening, wherever you are. Let me just share my slides quickly. So I'm hoping you can see my screen.
Yes, we can.
Brilliant. Good afternoon, everyone. My name is Ebenezer Oloyede. I'm a principal pharmacist at one of the hospitals in London and a PhD candidate in a university in London as well. So today we'll be going over, I have the pleasure of going over generalized anxiety disorder. And as mentioned, there'll be opportunities to ask questions at the end, but please feel free to send your questions as the presentation goes on. So before we start, I do like to reiterate that any character that is mentioned in this presentation is fictitious. So they're not associated with any one of them. They've been made up for the purpose of this presentation. And so without further ado, meet Mr. T. So Mr. T is a 25-year-old male. He's decided to go to his GP recently. And this is because he's complaining of muscle tension. And so this is really tight around his neck and his shoulder. It seems to be contributing to a headache known as tension headache. And we call this tension headache because if you think about a sweatband or hairband, it's a headache that's confined to around this area. And so Mr. T, when he discusses things with his doctor, describes struggling with getting to sleep for at least a year. Always appears to be tired, constantly restless, never able to sit down in one place and concentrate on tasks. And this also extends into his workplace. So he has poor concentration in his workplace, and he has repeated run-ins with his co-workers. And so these are usually over trivial things that should be overcome with a short conversation. And so Mr. T describes himself as a warrior since childhood, and it seems to worsen when he's under stress. And so the main reason why Mr. T has come to his doctor today is because he's currently having a hard time controlling these feelings of worry. It seems to be extending to every area of his life. And so as is usually done in the doctor's surgery, they decide to do a doctor's examination. And this involves doing the blood pressure, looking at the blood test. And they find that this guy is just a healthy man, just tense, normal vital signs, but he does have generalized muscle tension around his body. And so Mr. T is also, when they do the history, they ask, do you take any illicit substances such as cannabis? And he says no, he has no remarkable medical history, no hypertension, no cardiovascular diseases at all. And we'll come back to why that's important. But eventually Mr. T is diagnosed with having an anxiety disorder. So what is anxiety? I think it's important that we highlight that occasional anxiety is a normal part of life. Anxiety / nervousness is a natural reaction that you can get to a stressful situation. Often you might hear people say that this situation is making me to become anxious. Anxiety, stress, nervousness, they tend to be words that we often interchange in society. And so as this normal, healthy emotion, it usually comes when we face new and important challenges, such as taking an exam, giving a presentation to a room full of people, because you may be worried or anxious about how you are perceived, whether your message is getting across, etc. You may become anxious, or you may become nervous when you're waiting for a medical test result, or when you're waiting for the outcome of a job interview. And if you're like myself and you're an Arsenal supporter, every year that the football season starts, you will have a bout of anxiety. So this is a normal emotion for many. But the key difference between this normal emotion that we feel and an anxiety disorder is that as a disorder, this nervousness, this feeling of inner restlessness doesn't tend to go away once we've gotten through the situation, like the job interview or the presentation. And so it often leads to us avoiding, or the person to avoid, nerve-wracking situations like Mr. T in the future. And it can actually alter the way a person processes emotions and behaves, and also causing physical symptoms. And so by definition, this disorder is known as generalized anxiety disorder, or other people may call it GAD for short. And generalized anxiety disorder is the most common type of anxiety disorder that we know. It has a lifetime prevalence of around 7 in 100 adults. And when we say lifetime prevalence, this means like the proportion of people in a population at some point in their life that have experienced this GAD or generalized anxiety disorder. However, at any given time, if you take, for example, right now, how many people will be experiencing GAD, the number will reduce to 2 in 1,000 people, meaning that some people recover and some people go over the symptoms, for example. And so GAD is defined as at least 6 months of excessive, and this is key, excessive worry about everyday issues that is not in proportion to any inherited risk that the person may have around them, and it causes distress and impairment in one's life. The worry is not confined to features of another mental health disorder like depression. As my colleagues have previously been saying, around 50% of people that may be diagnosed with depression may also have co-occurring anxiety disorders. It is not because of psychosis, or it's not because of a result of substance misuse or physical health conditions. So to fall under the category of GAD, it has to be independent of these influences. And so some more figures for you. So GAD has been reported to be more common in high income countries. So the reported number of people that are affected in low income countries is around under 1% actually. And so this is quite different from the 7% that we previously mentioned. Why this difference? It's not very entirely clear, but it's said that it might be because of methods in which we are recording generalized anxiety disorder, cultural attitudes towards mental health conditions in low-income countries, And it actually might be that there's just a difference in the prevalence in the different populations. And so when we see GAD clinically is usually in adulthood. However, what the evidence says is that the onset is reported to be later actually in low-income countries. So later on, so late adulthood, going to older ages. And the clinical course is said to be more persistent. What does this mean? This means that the symptoms may continue for longer in these countries. And this could be related to access to services or different treatment options that are available, evidence-based treatment options. And so about for every 3 people that are diagnosed with GAD, 2 are females. So the prevalence is higher in females. And there's also a higher prevalence of GAD during pregnancy. And so this is why it's important for us to always be screening for anxiety disorders whenever someone becomes pregnant, and also postpartum, because it tends to be unrecognized in these periods of time. And the prevalence of anxiety disorders appears to be higher in people with chronic physical health conditions. So this is like cardiovascular disease, your hypertension, respiratory disease, and diabetes. And as previously mentioned, GAD can be associated with significant disability, affecting a person's way of working and carrying out daily tasks. So what symptoms can we expect? So to be diagnosed with GAD, a qualified psychiatrist will need to use criteria that involves having at least 3 of the following symptoms. And so this includes restlessness or nervousness, being easily fatigued, poor concentration, irritability, muscle tension, and sleep disturbance. It's also important to highlight that for it to be diagnosed in children, it only requires 1 of these key symptoms. And it's also important to highlight that this excessiveness of symptoms has to happen for at least 6 months and has to be out of proportion with any risk. And so there are other symptoms that we may see clinically, like muscle aches, sweating, dizziness, shortness of breath, chest pain, diarrhea, feeling of sickness, and any other sort of stomach issues. And so what causes this anxiety disorder? There is no single cause for GAD, but it's said to be that an increase in minor life stresses, the presence of physical, emotional trauma, genetic factors may all contribute to somebody having GAD. And so these 2 play a role in causing GAD. And so we know it as nature and nurture. So nature referring to our genetics and the factors that we adopt or we inherit from our parents, and nurture referring to our environment, the things around us, so the biopsychosocial model of things. Interestingly, there is also some evidence to suggest that there is a small association between maternal and paternal parenting styles, and the subsequent risk of anxiety disorder in children who are younger than 5 years old. So in particular, there's some evidence to suggest that a style of parenting known as challenging parenting, which is where you push your children to their limits, it seems to be associated with a reduced risk of anxiety when used by fathers, but not by mothers. So you can take from that what you want. There's another systematic review that says that bullying and peer victimization, especially in the adolescent years, can be associated with an increased risk of anxiety. Furthermore, a review of some controlled studies show that there's an increased risk of anxiety disorders in those that experience trauma versus those that do not. It's also important to highlight that there are other causes of anxiety. Around 20% of people that present with an anxiety are diagnosed with GAD. So this means that only 1 in 5 people will actually be diagnosed at presentation. And so there may be other things that are happening, or symptoms may not be at the threshold to be called an anxiety disorder. Physical health conditions such as thyroid disease, pulmonary disease, or cardiovascular disease can increase your risk and are strongly associated with anxiety. Furthermore, anxiety can be part of a mental health condition like psychosis or depression. Other anxiety disorders may also co-occur at the same time, such as panic disorder or social phobia. Also, as previously mentioned by my colleagues, there is examples of medication that we use commonly that can cause anxiety. This includes asthma medications such as salbutamol, beta blockers that tend to be used for heart conditions, and some herbal medications such as St. John's wort. Interestingly, antidepressants can also increase your risk of anxiety, especially initially on in treatment the first 2 weeks. And a history of alcohol or substance misuse increases your risk of anxiety both acutely and once you stop it, so on withdrawal. And so there are, while generalized anxiety disorder is your most common type, there are other forms of anxiety. This includes panic disorder. And so this is where you get like a sudden onset of anxiety, shortness of breath, nausea. You can actually get an inner feeling of you're about to die. There is social phobia as well that we know, and this is anxiety or fear that is often limited to social situations. And so avoidance behavior is very common in this condition. Another anxiety disorder is known as obsessive compulsive disorder. And this is anxiety that's directly related to compulsions or obsessions. PTSD, which is often in the news nowadays, especially with the events that we see in America, can be related to exposure to reminders of past trauma. So these are all other sort of forms of anxiety disorder. And as previously mentioned, they can actually co-occur together. So you may have 2 or 3 types of anxiety disorder in one person. And so how can we help as a society? I think it's important to highlight that encouraging healthy lifestyles is important. It's been shown there's a strong association with exercise and reduction in anxiety symptoms, supportive parenting, as previously mentioned, keeping in touch with friends and families, especially in the current pandemic that we're facing, and signposting people to scientifically proven resources, things that we know are evidence-based and that have been proven to help people. And so I guess I will end by saying, what next for Mr. T? Full recovery from generalized anxiety disorder is very achievable. Approximately 50% of people that have anxiety disorder will recover. And so with proper treatment, a decrease in symptoms, improvement in relationships, and a reduction in the utilization of medical care can actually be achieved. And so this slide provides various resources, which I think will be sent in the chat also. There are various apps that can be used for teenagers and also adults that have actually been recommended by BMJ as well. Thank you for listening. Any questions? It's been a pleasure.
Thank you so much, Ebenezer. If you stop sharing your screen. Thank you, thank you, thank you. For the sake of time, I think what I'm going to do is, you've answered one of the questions already. Somebody said, can you explain anxiety disorder? Which I think you have. So we're going to leave all the questions to the end, just for time's sake. If we can just show Ebenezer as well some hearts, tell him thank you. Fantastic. Thank you so much for coming. We appreciate it. Yeah, all the hearts are going up. I think we can do more than that with 72 of us here. Thank you. We see it's coming up more. So we did lose Yetunde Adeshiluka's network earlier. And if we just have our back, Yetunde Adeshiluka Oladejo, I'm trying to have seen you. If you can put on your video. I've asked you to unmute yourself. Please, if you've got questions for Ebenezer, put it in the chat and we will take questions at the end of everything. Thank you. Yeah, concise, informative, you did well. Yeah, okay. Yes, thank you. Yetunde, you're on.
Hi, Yetunde.
Hi, good evening.
Good evening. I introduced you earlier, but I think your network was playing up. So I was telling everyone how I met you on LinkedIn via your post you had made about your charity. Very important work you're doing. So over to you. Let them know what you're doing, why you're doing it, and what's coming up.
Good evening and opportunity to come on this.
Welcome.
Thank you so much, Flora. Thank you. Thank you for always, making this happen every time. We really do appreciate you. So my name is Yetunde. I run based on empowering women and girls. So what we do majorly is to bring an end to the issue of period poverty facing a high percentage of our adolescent girls in Nigeria. It's a really big issue that we are experiencing here in Nigeria due to the fact that we are facing a whole lot of issues now due to the fact that many of our girls are unable to purchase sanitary pads. The price hike for sanitary pads has gone up. We started this project about 2 years ago, and from 2 years ago till now, we've been able to reach about 2,050 adolescent girls with free washable, reusable sanitary pads, because we realized that most of these girls are unable to access sanitary pads. And because of this, most of them skip schools. Because of this, most of them use rags. Recently, next week, we'll be going to another to 2 villages in a particular area of Oyo State, where we just recently discovered that these girls still use lifts in these villages in a particular part of Oyo State in Nigeria here. Next week, we'll be going there to provide them with menstrual hygiene education, supply them with free sanitary pads that they'll be able to use.
Okay, I
And
think
when Flora saw what we are doing, she decided to make us come on this platform to women and girls in Nigeria. Have you give us this opportunity? Over, please.
thank you so much, Yetunde, for sharing on that heartfelt, charity initiative. We're all women and we all understand what this is. And also, even our men, I believe that you have sisters, you have moms, we all know, what the period pain it's like. So I feel that this is a very good initiative to support the girl child. If you want to be a part of this, Flora, how are they going to?
I'll post it in the chat. So
Okay.
Yetunde's network was breaking a little bit there. I don't know if everyone got what she was saying. So the initiative is called Girls Count Initiative, and the charity aims to provide reusable sanitary towels to girls in remote areas, in the villages, even some in the city who cannot afford the prices of
sanitary towels.
Sanitary towels at the moment, not even just at the moment, even from when she started, but of course the price has skyrocketed. So that's what we're supporting. She's also provided bicycles for some children in a village in one of the states. I can't remember now. They went there on an outreach and they just found out that they couldn't get to school. They were walking miles and miles. So with the help of donations, they were able to get bicycles for the children. And of course, it's not only helping the children, it's helping the parents, because the parents can also use the bicycles to go to the farm, do different things, go to the market, and bring income into the family. So it's not just going to affect the child, it's the whole family. Anyway, I'll post her details in the chat if anyone would like to be part of that and make a donation. Yeah, thank you.
Thank you so much for sharing that. We cannot all be at the same place at the same time, but I believe that we can always all support one another, and that way we can reach a lot of other people. The next speaker, which is our last speaker, is going to be on treatment of depression and anxiety. So we've heard about depression, we've heard about anxiety. Now we're looking at the treatment. There's no point us talking about all of these things without, having a treatment plan. So I've got the last speaker, Banke Jahini, who is going to take us through. I'm just going to read her bio. Banke Jahini has been a qualified pharmacist for over 30 years. Her specialty is mental health. She is currently the lead pharmacist for governance. Banke enjoys traveling, and she likes to look for meanings in numbers, whatever that means. She likes to look for meanings in numbers. Maybe you can explain that for us before we start. It's a course now, so if you can unmute, yeah, good.
Okay, thank you very much. When I said I like to find meaning in numbers, it just means there's a lot of data that is around now, especially in the world of big data, Google, there's data, everything we do, everything we interact with comes with data these days. And it's important to actually understand what the data is telling us, or what does it mean. So when you say 50%, what does that even mean? Even just little things like that. So I like to find meaning to numbers and break it down in such a way that everyone can understand. Because if I understand, then most people will be able to understand.
Thank you so much. Yes, you can go now.
So thank you for giving me this opportunity to speak today. I'm going to share my slides, and My topic for discussion today is to talk about the pharmacological treatments for depression, mainly depression, and just a little bit about anxiety as well. So we have heard a lot. I mean, it's actually a little bit depressing, a bit sobering as well, to hear about mental illness, depression, the symptoms, the outcomes of it, suicide, comorbidities, the burden of depression itself. But without focusing much on the doom and gloom, there is hope. I think one of the previous speakers did mention that. So there is hope. And hopefully I can touch on some of this today. So the main focus, as I said, is going to be about medical treatments in terms of pharmacological treatments, medication. But it's also important to know, to learn that there are other forms of treatments that you can use for depression. And sometimes you might have to use a combination approach by combining two different things together. So I'm talking about medication today, but there's also psychological and psychosocial treatments that could be linking it with social networks, finding a space in spirituality, exercising, those sort of things can help. The last two, electroconvulsive therapy and others that I've mentioned, that is going into another dimension, so we probably don't need to talk much about that. It's important to know that sometimes treatments might not be effective. So for example, it might be difficult to even get yourself out to receive psychological therapies or go for counseling. And medication might be the only thing that might be easily accessible at that point in time. So so the focus of this talk is about that. So what treatments do we use in people who have depression? So we do have antidepressants as a mainstay, but other things have been used as well, especially in addition. Sorry, I've just seen all sorts of things here. Antipsychotics are a class of treatments that may be used in addition to antidepressants. We have mood stabilizers, we have anxiolytics, such as lorazepam. I'm going to talk about that a bit. We have hypnotics, and we have other fancy treatments as well that we're not going to necessarily touch on today. So when I'm talking about antidepressants, I am talking about there are different factors to consider. So antidepressants would most likely be prescribed by a doctor, and preferably a psychiatrist, because they are the specialist doctors that can treat people with mental illnesses. They have to discuss things about rationale. Why are we even prescribing these antidepressants? What are the benefits that one could achieve from it? What are the harms, side effects? What are withdrawal effects? Because when you take antidepressants, then you have to take them for a while, and then you have to determine when to stop them, how to stop them. You have to inform the person about when to expect the antidepressant to start working. And also there's also monitoring involved. So antidepressants are not a class of drug that you can just buy over the counter, even if it is available. It is something that it needs to be prescribed by a specialist so that they can carry out all those things I've mentioned. So when we say response, what are we talking about? So this is in moderate to severe depression. So these figures are for moderate to severe depression in general adults. So this is not in kids, and this is not in older adults. So what we know is that there are so many different antidepressants. All of them are effective. Maybe about 50%, so I was talking about numbers. So about half of the people that take antidepressants will probably most likely respond to them. And when we're talking about response, again, the way that is measured is quite important. So they're not happy pills, they're not happy medication. They're not going to make people to be bouncing off the walls and be extremely happy. But what they do is reduce those symptoms. And when we say they reduce the symptoms, they reduce it to roughly about 50% as well. So that 50% number keeps popping up. So you might feel a little bit better, or like half better than you were before in terms of those symptoms that we've all heard about. Placebo is one of those things that when you're looking into trials of medication, they would often give another group of people what we call a placebo pill, which is just nothing. So it's not an antidepressant, it's just to test the antidepressant against. And some people will respond to that as well, because people do get spontaneously better even when they're depressed. And we have maybe about a fifth of people who would not respond to any treatment at all. The most effective period, the first 2 weeks is when you see the greatest improvement. However, it may take 4 to 6 weeks before the person themselves start noticing any changes. So there are different types of antidepressants. The most common classes are the tricyclic antidepressants, which they're the old as well, so the old ones. And we also have the SSRIs, also known as the selective reuptake inhibitors. We have the monoamine oxidase inhibitors. I'm not going to focus on those, and we have other groups as well. So these are examples, based on the different classifications. So the ones in red are the ones you will find in the WHO's essential medicines list for depressive disorders. So all the SSRIs are on that list, and you have amitriptyline. So this essential medicines list basically from the WHO is to say that for any country, you have to have at least a minimum of these medicines in your formulary, making it available for people who might be depressed. Antidepressants as they are, even though they're all more or less effective, there are differences in the way they work. I'm not going to go into too much detail about the pharmacology of them, but antidepressants in general tend to either increase serotonin or noradrenaline. And these are neurotransmitters or chemicals, if you like, in the brain. So these chemicals have been shown to be a little bit reduced or not functioning properly in the brain. So the aim is to actually increase them or make them more available. So, and they do this in various ways. So how do you choose between an antidepressant? Which one do you go for? Because there's so many different antidepressants, as you can see. Well, it just depends really. And this is where you need an expert to be able to make that choice, again, with the patient themselves. So we have patient preference because they may prefer one to the other. Often depression can be comorbid with other psychiatric disorders. So the person may have anxiety as well. They might have other conditions as well. They may have schizophrenia. So it will depend on other conditions as well, because you don't want to make that other condition worse or take into account like interactions and things like that. It could be that they've been on treatment before, so you might want to consider what that looks like then. It could be about tolerability or side effects. It could be about safety in overdose. So we've heard about toxicity. Well, we've heard about people with depression having a high risk of suicide, completed suicide. Some of these medicines, some of these antidepressants, if someone takes it in excessive doses, that could also actually kill them. So we don't want to give them the tools that is going to help complete suicide as well. You have to consider what other medical conditions they have, other medication, and if there is a familial response. So it could be that in this family, they tend to get on well with the SSRIs, so you might want to keep that there as well. So the SSRIs, the selective serotonin reuptake inhibitors, they usually are first line, especially like in the maybe Western countries, so like UK, Europe, in the US, they're usually the first line treatment. Most of them have come off patent now, so they're not that expensive anymore like they used to be when they first came out. What they do is increase serotonin in the brain. They are useful in people who've got other comorbid medical conditions. So if someone's got diabetes, for example, it may be preferable to the other types of antidepressants. They tend to be generally well tolerated. So people will find that the side effects are somewhat bearable. That's not to say they don't have side effects. They do. All medicines have side effects, but they tend to be generally bearable. But there's caution in people who have bleeding disorders because they can increase the risk of bleeding. So these are some of the side effects. Insomnia, we've heard about that. Ideally, you don't want an antidepressant that's going to make you even difficult to sleep when depression itself actually is causing some insomnia. But once the drug starts kicking in and starts improving the mood, then the insomnia is less pronounceable. They can cause agitation, again, mostly at the start of treatment. The most problematic side effect that, again, that is not really well discussed is the sexual dysfunction. And this can occur in both men and women. And sexual dysfunction can go into like erectile dysfunction or orgasmic disorders and things like that. Well, I won't dwell too much on that, but there are ways in which you can manage all these side effects. So the tricyclics is the other common class that may be prescribed across the world. They are more like dual reuptake inhibitors. So the SSRIs increase serotonin. So the tricyclics would do both usually, or they might focus more on one neurotransmitter than the other. They're not as well tolerated. So it might be one of those you might want to be cautious about, especially in older adults or in children as well. In fact, it's not recommended in children, to be honest. They are more likely to be associated with cardiovascular effects, and they're more toxic in overdose. So if someone is demonstrating suicidal ideation, you might want to be cautious about using this antidepressant in them. They're a little bit more sedating than the SSRIs, and some people actually find them really, really sedating. So they might cause drowsiness in them. That could be a good thing if insomnia is a big factor for that person. Some of the side effects, again, we've already mentioned, but they also include things like constipation, weight gain, blurred vision. Again, you can manage them somehow. So I put some frequently asked questions here because people do ask questions about antidepressants and things like, how long does it take for it to work? So I would say yes, immediately, because they start working pretty much straight away. But it might take a few weeks for the person themselves taking it for them to notice the difference in their mood. How long does one need to take an antidepressant for? Again, it depends. There's no straightforward answer to this. It might depend on the number of episodes of depression they have. So we do know that depression can recur. It could be a recurrent disorder. It could depend on the severity. Generally, if you've had more than one episode of depression, you would most likely take it for longer. And that could be a year, 2 years after you have actually responded to the treatment. Can you stop it abruptly? The answer is no, because you could get discontinuation symptoms. The condition itself also you can get relapse symptoms as well. And the discontinuation symptoms can be quite frightening for some people. And so yes, it has to be withdrawn very, very gradually. So this leads to questions that people say that they might be addictive. And in layman's terms, or in terms of how people feel when they're trying to come off it, then addictive might be a word that people use, but we do have a medical definition for addiction that antidepressants do not quite fit into that category. So I would say, no, they're not addictive, but they do require gradual discontinuation once you've reached the remission. So people do ask as well, oh, can you take them in other medicines? Yes, you can, but it depends on what that medicine is. So you have to check with your doctor or pharmacist to see which one is going to interact or not. I can't swallow tablets. Are they available in other forms? Well, depending on the country, but they are available in various forms. And that could be capsules, liquids, or drops. That was my alarm, but I'm almost coming to the end anyway. So in summary, the management of depression is very complex. Diagnosing it itself is one thing. So we have touched on that for older adults. Knowledge of pharmacotherapy is important. So that's why you need an expert to actually prescribe these drugs for you. Appropriate selection is important. Monitoring, you have to have a clear strategy for what to do if it doesn't work, because it might mean you have to try several different options before you get the right treatment combination. Switching between treatments is a thing. So there is a way in which those things can be done. It has to be done in a professional manner. It has to be done by a professional. Adding other medicines or other treatments to it, stopping treatments, those are all parts and parcel of the treatment of antidepressants. So I've just got 1 or 2 slides on treatment of anxiety disorders because, believe it or not, antidepressants are actually the main treatment for anxiety disorders as well. So we had Ebenezer talk to us about GAD, which is Generalized Anxiety Disorder. There are other forms of anxiety disorders as well, and antidepressants would be the ones you would use there as well. So in addition to antidepressants, we also have other groups, so like the anticonvulsant called pregabalin, and we also have the anxiolytics or the hypnotics. So this may be familiar to some people. So here we mention things like benzodiazepine, and diazepam actually is also, again, a drug that is on the WHO essential list for anxiety. And yes, so like I mentioned, SSRIs in particular are used for generalized anxiety disorder. The difference is that the duration of treatment is often longer and the response is a little bit slower. So people might take a number of weeks before they even realize that it's getting better. And in some types of anxiety disorders as well, higher doses than you would use in depression might be needed. Here are some of the benzodiazepines or anxiolytics that might be used. So the important thing about these ones are they are not for long-term treatment, they're only for short-term management of anxiety. So it could be that it's used when required, or if used consistently, then it should be limited to less than 4 weeks. And the main reason for this is that they actually can cause addictions and they cause dependence of all sorts. Side effects may include headaches, having a cloudy, fuzzy head, blurred vision, respiratory depression, but that's when you take loads of it or if it's given parenterally by IV infusion, that sort of thing. You have to be cautious in older adults because it can lead to increased falls in those people. And when taken for 4 weeks or longer, it has to be gradually withdrawn. Otherwise, if stopped abruptly, it could increase the risk of withdrawal seizures. And they tend to interact with other sedating drugs as well. So people might be on other medicines like sedating antihistamines, for example. Quickly on Z drugs, they are just hypnotics. So they are used for, again, short-term treatment of insomnia. They have similar side effect profile to benzodiazepines. And lastly, we have antihistamines like hydroxyzine or promethazine. Promethazine also has a common name by Finnegan that people will call it. They're not usually recommended, but sometimes may be used again for short-term management of the accompanying insomnia. So thank you for listening. In fact, thank you for listening and staying to listen to my talk. It's not easy listening to other people go on about so many different things, but I hope that is somewhat informative. I've been asked to put up this information about where to seek help and information from. I think we're probably going to circulate that a little bit more as well. There's also some information on the WHO website where you find like a fact sheet about depression. So thank you.
Thank you so much. If you want to stop sharing, like I always say, if we can just show us some love and say thank you. We appreciate you all of our speakers. You guys have been phenomenal. So if I can just have all of the speakers on the screen and let's just do our questions. I'm just gonna add people to spotlight.
Bumi,
yep.
Can we do the announcements first? Then we go to the questions?
Okay, yes, we can. Yeah, of course we can. So we've got a few announcements that we would like to make. So the first one is, I'm gonna post a feedback link in the chat. I mean, we've still got 64 people at 1824, 624. That is a very good number. Thank you all for being patient. Thank you for waiting. Okay, I'm going to put a feedback link. We just need you to complete that feedback form. We want to know how you feel. You know, we want to improve. I know that we can say this is excellent, but trust me, there's still various ways that we can improve. So whatever way that you think that, oh, you know, I think you should have done this here, put it on the feedback form. We want to serve you better. Okay. And then the next, save the date. I've got it already in my pencil in my diary, is the 16th of July. 16th of July. So you want to maybe pick your phone right now and put the date in. If you do it tomorrow, you might forget. The 16th of July. And the topic is something that I love. Trust me, because we all love to use the cream on our skin. We want to look good outside. But how is our skin? What do we need to do also inside? You know, I'm looking forward to that topic. The topic is skin. So you also want to like our social media channels, which is YouTube, Facebook, and IG, Encapsulate Health. All of our old videos that we've done in the past, if you've missed anything, everything is on it. I learned about, you know, how to take care of my teeth here. I've learned how to take care of my toes, my feet. I love the feet. I love my feet. You know, we all love various things. So I've learned so much. You want to go back to those videos. You want to share it, especially if you're a health care professional. You want to share it with somebody and say, you know what, I stumbled on this page. You want to subscribe it for next time so that we can all, you know, learn from one another. So those are the announcements. 16th of July, topic is skin. Like our social media channels, YouTube, Facebook, and IG, Encapsulate Health. And you want to also, the feedback form is there. You want to help us to fill that in. So thank you so much again. If I can have all of our panels, everyone, we're going to add as much as possible, but we need your videos to be on. We need your videos to be on. I'm adding you all to spotlights. We need your video. We need Dr. Tolu. Yes, thank you, Kemizia. We need Ebenezer as well. Okay, I can see Dr. T. I'm gonna just add you as well. Ebenezer, if you just put on your video, then I can see you. Okay. So yes, I've got a lot of hearts for all the speakers. Ebenezer, we're waiting on you to put on your video. Lots of hearts, lots of love. We're all, you know, rooting for you, cheering you guys on. Thank you so much for pouring yourself out. Now I've got loads of questions and I'm gonna just look out for them, hopefully, because there's so much on the chat. Okay, so I've got, no, we've done that one. Just be quick. Okay, yes, so I've got the first question. Any one of you can answer. What about, I think this is on, and no, not on sleeping, insomnia. What about sleeping late and waking late, mainly at the weekend? So I think this person normally would sleep late, and at the weekend, then they try to get their bodies back and sleep mainly at the weekend, sleep more at the weekend. I think that's what the person. So is there anything wrong in that? Maybe Dr. Tolu can answer that, because I feel that you dealt with insomnia. So this person sleeps late, but at the weekend, then they try to get more sleep. Is anything wrong with that?
Well, generally, well, I work with children a lot, children and young people. So generally, I say routine is key. When you're looking after children and young people, routine is key. So I know that there's always this exception that, well, on a Friday night, there's no school on Saturday, so sleep late. Well, you can allow that, but some children don't respond to the break or the changes in routine. So if a child does well and they're able to, you know, sleep late on a Friday night, on a Saturday night, and they're able to go back into the normal routine on a Sunday night, then it's absolutely fine. For adults, I think that's well, it depends on how you're able to handle your time. So routine is key, is what I always say for kids. Stick to the routine, it always helps.
Thank you so much. Okay, this is very insightful for me. Thank you so much. My kids love pressing phones till late because I do. I just learned this, that all phones in tray at a specified time. Okay, that's more of a comment. Thank you. Next question is, it's really a big challenge. Okay, no, so just trying to look through. What can we do to help our older adults? It's a huge concern for me because when we visit some in their homes to provide them food, it makes us so unhappy seeing them alone in their homes with no food and no help. Anyone?
I think, like we said before, I mean, I think that question is from someone in Nigeria, right?
Yeah.
I think it's a wider society issue of how we can help the older adults, from individual families to the whole society. It's a difficult one, but I guess from my point of view, we start with the individual families. Like I think someone mentioned about children abandoning their parents or something. I think we are charged to look after our parents when they're older, and that's what we need to do as much as we can. Everybody has their individual circumstances, but I think that's where we need to start from. If you are I can only speak about Nigeria, the infrastructure for homes, and I know Olabode mentioned it earlier about nursing homes. It's just, that's still a new thing, but I know those are coming along, and I don't know what the acceptance is within our culture, but they do exist. I don't know if anyone else wants to say anything about that. Anyone?
I know that there is, I really don't know what the name is, but I know there's a lady on Facebook that I know that does, I think she's a doctor here, and she has a nursing home that she's, went to Nigeria to get done. And I know that she's doing really, really well. The news is there. It's not, like you said, I don't think it's something that is really held there, but yeah, people are doing it. Okay, so I'm just going to move on quickly on that one. So
unless there's someone, sorry, Bumi, unless there's someone in the audience that wants to comment about that, how we can help the older adults, they can raise their hand so that, we're all discussing this together.
Yes, I agree. So I just don't want us to think that we all have that information. If you know something, please, you can raise your hands and I can unmute you if you want to share.
I think I would like to say that with our older adults, I know there's a lot of work that has been done by faith organizations. And I think we all have a responsibility to flag this up. If you belong to any faith organization at all, and they are looking to help people, I think to flag it up that it is an area for that needs some thought and some consideration, because I know a lot of work goes into young people, a lot of work goes into homeless people, but also the older adults, especially ones that don't have help. I think faith organizations can also shine their lens upon that. Thank you.
Thank you. And just adding to that as well, I mean, I know that sometimes all of these older people, some of them are not, directly blood family, but I think there's a duty of care for everyone as well. That if you find someone, maybe an older person next to you, your neighbor, to just reach out on them. Oh, how can I help you with your groceries? What can I do to make you feel better? So that way, at least we're all helping, and we're making the generation a better place. We're making the community as well a better place. So the next question is, okay,
no, hold on. Dr. Rira's got her hands up. She wants to contribute.
Okay, thank you very much for giving me a little moment. Just so I'm not too certain about the demographics and the age of all of us here, but I don't know. I'm sure maybe we all have parents. And what I'm seeing happening in Nigeria, again, I'm speaking from Lagos, is a lot of children who are now adults, really. They're leaving their family, leaving their parents back, because everybody's looking for how to make something of themselves and leaving away, and then maybe sending money back. And we're becoming more Western in our ways, where everybody's minding their own business. So the traditional family units that Nigeria I mean, we all knew and we're grown up. I hope you can still hear me. I'm sorry, I'm on the
Yes,
road.
we can.
Yes, we can.
So the traditional family unit where everybody's together as the mother, the aging mother who is now a grandma to your own children, is still there and not really feeling that whole depression. We're losing it. And we are not able to, because the society is not built, and it's not even tending towards that, of where you say, okay, can we have maybe like a social gathering where elderly people can stay together and at least have some form of communication or a to-do activity. So these are the sort of things that we need to start thinking about actively, not leaving to maybe one or two persons. If you some of those who may have influence in politics or wherever, so that we can actually, because we're in one breath, we're trying to make them live longer, hopefully healthier. But to do what? What's the point of being 80, 70, 80 and not having good quality of life? Because everybody has left them, and you send money to a caregiver who is just thinking in terms of, oh, the money I will get at the end of the month, and not particularly vested in the quality of life. And we don't also like the idea of putting, there's a difference between a hospice and a home. Because here we think that, oh, when the people have a problem, medical problems, so still put them somewhere, pay the money. No. As opposed to, abroad, you have, in the Western world, you have like a proper home, which sometimes they will, rail against initially until they find out actually they're having a good time there because they're with people their age mates, they can play games, they can have gists, So I think those are the sort of conversations we need to have and deliberately look into how can we improve the quality of life of these older, elderly people, not just older generation, elderly people who we are struggling to make sure that they live longer. So it's not just quantity of life, but the quality of life. Now, as I don't know if we can. I don't know. I
Thank
don't know
you
if
so
I've helped,
much.
but putting you what it is that I'm seeing and how we who can, if even for your own dad or mom, because in one breath of you are like, okay, I've provided this for them, provided that, but they want you. They want company. They want you personally. So it's not enough to say they're okay and you get somebody to get them buy groceries. No, sometimes they're not even hungry. They just want to be with you. They want to spend some time with you. They want somebody to engage them, their minds, talk to them, so that waking up tomorrow morning is worth it. I think those are the sort of conversations we need to start having, because I'm seeing elderly people come to my clinic with maybe a driver or somebody who say, okay, please just bring them. And there's nothing wrong with them. But they just, that's now going out for them because there's nothing else for them to do.
Thank you.
Thank you so much.
I think this issue is bigger than what we can discuss here, but it's something for everybody to think about in their own sphere and how we can deal with it. Like Tolu said, faith-based group is something we need to let them know and let them be aware of. That is something to be looked into. That person that is coming to your clinic, they just want to talk. They are lonely. They're lonely.
I've got this in there. Yes, and I'm just going to ask you to unmute. You can share your contribution, please. Before we move to the next question.
Yes, thank you. Thank you so much. So I just wanted to share a few things that I had discussed with a friend today. So today she was just telling me because she'll be leaving Nigeria very soon. So she was now telling me our fears concerning our parents, because the parent had 2 kids. One of them is not in Nigeria. She wants to leave too. And the 2 parents would just be. So she was so concerned about what she would do when she gets out of the country, and the parents are already old. So we're now talking today. I was now like, probably we need to start looking at having homes, old people's homes, where in different parts of Nigeria, whereby this, our older adults could go to. So I'm just trying to, that's why I'm so concerned.
I think we've lost you there, Yetunde.
Over here. Thank you so much. That's just my contribution.
Thank you so much. We're going to move on because honestly, I feel that this is, it's bigger than us here. I agree that, a lot of our parents, what they need is just talk. Sometimes they just want to talk. They just want to speak an hour, 2 hours, just knowing that you're just there for them. It's not really the money per se, but yeah. So whatever influence that we all have, wherever we are, if you, faith definitely is the best place, I'll probably say, to start. Whatever little that we can do or contribute in our own little way, let's all start thinking about these things. So the next question is it recommended in absolutely all instances of being depressed to take the drug prescribed by your doctor or psychiatric? or can you self-medicate on an over-the-counter drug just on the recommendation of, say, a friend?
Suppose that's for me, right? Under no circumstances should one self-medicate on advice of a friend, because it goes without saying, unless that friend is a psychiatrist or a doctor that specializes in treating depression, they wouldn't. I mean, I hope the talk highlighted some of the challenges when it comes to treating depression. Depression is not, I mean, depression is a serious condition. And as we said, the outcomes in some people can be catastrophic. So people can actually end their own lives. So for that sort of condition that the consequences can be so severe, I wouldn't take it lightly and just self-medicate or go on the advice of a friend. It is very important to seek the advice of a healthcare professional that actually specializes in mental health as well, so that they will know what kind of treatments, because it may not even be a drug that is required. You may have, or you may even have a physical illness, underlying illness that needs to be treated, and your depression or the low mood might be a result as some other imbalance in the body or some other physical health condition that needs to be managed. And you taking medication that is being recommended by a friend may actually worsen that underlying condition. So please, under no circumstances must this be done.
Thank you so much. Next question is there a risk of symptoms recurring, even when a drug is stopped correctly in a gradual withdrawal form? Are these drugs to be taken for life?
Yeah, that's a great question, actually. And yeah, it's one that there's no straightforward answer to. But yes, depression can be a recurring condition. In some people, it is a chronic condition. Some people go through periods where they go through remission and they're completely well. But as we know, there could be triggers in one's life that could trigger depression again. And if you've suffered from depression before, there's always a fair chance that you could suffer from it again. So it is possible you might have to go through periods whereby you get treated, then you get well, you come off medication gradually. Further down the line, something else might happen, or you may never ever get depression again. You know, it really is quite difficult to say, because life events can be triggers, and we can't always predict what kind of life events people are going to come across. Some people can manage their depression depending on the severity of it. It doesn't always have to be medication, like I said. But if someone is severely depressed, and when we talk about severe depression, they're actually not eating and they are at risk of possibly starving themselves to death. They're not looking after themselves. So through neglect alone, that person could die. In that sort of situation, you really do need to intervene. And even medication might not even be what you're using at that point. You might be using some higher level treatments just to get them out of that phase.
Thank you so much. The next question is this: when a patient is depressed and has been on drugs for like 10 years, yet complaining of one side effect and the other, what do? Gastric problems, sexual dysfunction. Can the patient stop the drugs?
Okay, so just from the description of the side effects, gastric problems, sexual dysfunction, probably most likely an SSRI, because that's typical of them. And some of those side effects don't often always go away as well. In that sort of person, really depending on the drug, depending on the journey, because they may have tried several different antidepressants before they reach that one. It really all depends. If there's scope to switch to something else, then that would be the advice, to try another type or class of antidepressants and see if that's going to alleviate the problem. You could try and treat the sexual dysfunction depending on the type of sexual dysfunction it is. The gastric problems, again, I don't expect those to last years and years and years. So it could be that maybe they need some form of investigation. Again, I'm not quite sure what kind of gastric problem that could be. But yeah, there's always things to look into. So investigate first try something else, try different options. But if the depression is still a problem, or like the antidepressant is not even helping that much with the depression. So the question has to be there whether it's actually worth carrying on with the antidepressant despite so many side effects and the drug is actually not working. So again, it's not a simple, straightforward answer. Each case has to be looked at individually.
Thank you so much. Now, question, what is cardiovascular?
Oh,
you mentioned not using the depressants for this.
Okay, so cardiovascular conditions are things like having hypertension, or people might have cardiac disorders as well. So I think I mentioned that in relation to the tricyclic antidepressants. So they can have side effects that could affect people who may have hypertension or who may have other cardiac, like heart problems. And in those people, they need to look into alternative treatments for them.
Thank you. So someone says, are there information sources on mental health in Nigerian languages? That's actually a very good question. Does anyone know? And it could be anyone as well. You know, it doesn't have to be the speakers only. Does anyone know whether there are information sources on mental health in Nigerian languages?
I'm looking for Mrs. Lawa, but I think she's dropped off. It might be her network and someone else. Okay, that we'll have to look into and get back.
Yeah.
Yeah, let's note who asked the question and we'll have to sort that out.
Okay. So yes, I mean, there are lots of great work, highly esteemed facilitators, great work to the speakers and organizers. And someone made a comment, I think this is, immigration has not helped. Children are moving away with their parents and with their families and leaving parents and elderly relatives behind. I think well-structured residential nursing homes will help to alleviate all of these issues. And she says many thanks to all, really insightful. I haven't got any other question after this. Does anyone else have a question? You can just put your hands up and we can unmute you. Okay, otherwise, thanks everyone. Thank you for coming. Don't forget to fill the feedback form. I've put it back again in the chat. Thank you to all of our speakers. We appreciate you all. And I'm just going to pass it back to our host, Encapsulate, Flora, please.
Wow, thank you, everyone. Thank you for staying till this time. When people ask me how long is it going to be, I say, well, this is the planned time, but we always go over because people are always engaged and asking questions, and we try and address them as much as we can. That's the whole point of us being here. So thank you, everyone. Thank you for joining, and I hope this has been insightful and impactful. Please do complete the feedback form for us. Please share the YouTube link, which will come later, or share the information. And remember, do not self-prescribe without, make sure you see a healthcare professional, your doctor, your pharmacist. Do not take any medication on your own accord. Always seek advice. And don't self-diagnose. You might decide it's this and it's something else when you go and see your healthcare professional. All we've said here today is current at the time of this recording. I always like to say, and should not be any substitute from any healthcare professional advice. Once again, thank you so much. Have the good rest of your weekend, and God bless. Cheers. Bye. Speakers, don't go.